I'm always ready.
Dr. Paramit.
Till now, how many been logged in?
Sir,
just say 512 54321. Dinesh.
Yeah. Fine.
हाँ दोनों है सर, यूट्यूब में भी है, वो वेबकास्ट में भी है.
Yeah. Yeah.
नहीं सर, अलग ही रहेगा.
Good evening everyone. Good evening everyone. Warm welcome to everyone, especially the speakers first. And to start with, on behalf of Sun Pharma, let me give my warm welcome to the audience as well as the speakers. And it's my privilege and pleasure and honor again to introduce, when it is, though Dr. Satish Jain doesn't require any introduction, but still it's my honorable duty to introduce him, and he is a well-known across the world. So I'm very happy to welcome him. Sir, heartiest welcome to you. And today we have Dr. Monish Grover. Monish Grover from SMS Medical College, Jaipur. And we have Dr. Rajiv Pachori from Agra. And we have we have Dr. Paramita from Mumbai. And today we have one more special occasion, Dr. Rajiv Pacheri's birthday. Very wishing on behalf of Sun Pharma, wishing him a very happy birthday.
Thank you.
And to give a small introduction about the webinar, last week, the webinar what we had, I mean, actually that it has gone like a marathon, and almost it was 3 hours. Surprisingly, the entire 3 hours were more than 3,000 doctors. I mean, so that itself shows the substance of the webinar, which has been done, which has been led by Dr. Satish Jain. And today, in the beginning itself, then when we found that it's more than 2,600 doctors have already logged in across the globe. That really creates, lots of vibrations among the entire ENT fraternity. So nothing more to speak about this webinar. I think that more and more substance will come out, and this will have lots of take-home message because of the prominent doctors what we have in the panel today. And once again, my heartiest welcome to all of you on behalf of Sun Pharma. This is Mahendra Varman from Sun Pharma. Thank you very much. And over to Dr. Monish Grover.
Okay, Monish, it's okay. Good evening, all my friends. Good evening, all my friends from my state, my country, abroad, and all over the globe. Good evening at 5:30 in India. And let's start with one topic, today's discussion about the impact of radiology on the management of sinonasal pathologies. And that is, it looks a very simple topic, but I think if we sit, we can spend hours on this topic because it is very important part of any sinus surgery. Unlike the ear or laryngeal surgery, this sinus surgery requires this part is radiology in a very, you can say in a perfect way. We should know exactly what we are going to do, and that is best GPS for our surgery is the radiology. And that we say that I would like to thank Sun Pharma again for this wonderful academic research. So when we take any surgery, sinus surgery, and to get a perfect result, just to avoid this bloody sinus, I won't use the bloody sinus, but bleeding sinus. So we just prescribe, we just give a list of investigations to our patients, and I think we give a bunch of investigations. But I think the best investigation, most needed investigation, is the radiology, because we want to get this perfect result in all our cases. We want to have a post-operative perfect, no complications, because the complication at any level. Just see this red eye on table, red eye on the table, red eye on post-operative time, red eye in after a few months because of not getting perfect result, because of getting complications. We have to avoid this red eye, and that means we should get a perfect case without any complication. That's why radiology is still the most important and reliable one investigation that we should take care in our future. And I think starting with the X-ray, we all know that X-ray has very limited role in sinus surgery. We see so many cases, but it is a very bitter truth that in our clinical practice, most of the time we get the cases being referred by someone or being come to us after getting complaint that previous surgery was done without use of CT scan. So CT, I would say X-ray has very limited role or in fact no role in any sinus surgery. CT scan, proper CT scan and proper MRI, and what is the proper word that we will discuss, and Dr. Satish Jain will elaborate everything in detail. CT, where is the role of CT scan or MRI? That's we say that, and to have a perfect cool operative time on table without any stress, without anything, because you have a GPS with you. GPS means a big good radiological investigations are lying with you on table or in your screen view. That's why keep in one mind one concept, and that is the appropriate radiology for anesthesia. This appropriate word is very much important because whether you are operating a AC polyp, whether you are operating a polyposis, whether you are operating inverted papilloma or a extensive fungal sinusitis with interconnect complications or any tumor, this you should have a appropriate radiological investigation with you. That is all I wanted to say. So I would like to. Today we have question hour session. That means because previous that program, few points were left, so we will discuss for at least half an hour, 45 minutes. We have with us Dr. Monish Grover from SMS Jaipur. But Dr. Monish, before switching to question hour, I would like to ask one thing. You are working in Gowns Hospital where some things because we speak protocols or any what your suggestion for you get advice in your cases at SMS or you would advise to any working person who is working in the Bond Hospital. Dr. Monish.
Yeah, good evening, everyone, and thank you, Sun Pharma and Satish was Rajiv sir and Paramita for bringing me here. It's a privilege to be here, and I'm wishing you, Rajiv Pachari sir, a 50th happy birthday once again. Now, as far as the question goes, right, in a government setup, probably the working conditions are a bit different. However, as a protocol in our institute, that is in Jaipur SMS Medical College, we do, before any surgery, as you mentioned, it is imperative to get a CT scan done. Now, as we all know, the goal of the CT scan is, or when you're doing a CT of the PNS, is to define a very kind of an irreversible disease, right? It's a disease component which does not respond to conservative medical therapy, and therefore, if it requires an endoscopic sinus surgery. So, as a protocol, I think it is very important. I'm sure we will discuss this in detail. That you do not get, a CT scan, and when the patient presents to you right at the first moment, right, when the patient is having maybe let's say an acute episode of sinusitis or acute cold at that particular point of time. So maybe a 7 to 15 days course of, if required, antibiotics if the patient is in acute sinusitis, or at least a decongestant and nasal steroids, followed by a CT scan. And even before the CT scan, it's always advisable to ask for a vigorous nose blowing, so that any blob of mucus which is there is actually not really seen as disease in the CT scan. Luckily, at our institute, we have 3 CT machines running 24 hours all through the year, all the days. So it's like we are doing approximately 250 CT scans at a very economic cost. So there's not a huge waiting. In fact, you send the patient and the CT scan is usually done in the same day. So that has actually helped us out, not to go away from the advised protocols as to a CT requirement whenever you require. So we follow pretty much the same things. That's pretty okay. So I don't think government or private, we should not really differentiate versus when a patient requires a CT scan. It's a clinical decision, not based on the other factors which come into place out here.
Okay, thank you very much. Thank you. I think we should move to question hour session. And I think a few questions be selected for, because so many queries were there, almost 800 questions were there, so we selected very few. I will request Dr. Paramita to start with Dr. Satish. And one announcement is there, because today we are going for radiology, and this thing next week on Thursday, time we will let you know. We will go for one surprise, and that would be the first time in our India that we would start with the live surgery, with the first basic surgery, and then followed by talk on complications in sinus surgery. So that is, I think, Thursday timing, I will discuss and let you know. Dr. Paramita. Paramita, you are just unmute your
Yes. Okay. So good evening, everyone. We got an immense response in the last session, and there were more than 800 questions, and we could not, of course, attend all the questions. But in his lecture, we could cover most of the questions they were asked. Um, and there were also many queries asking for the video. They wanted to see the video again. There were many ENT surgeons who could not see the video. So for all of them, I would like to tell that on YouTube, you can just type Satish Jain understanding chronic rhinosinusitis. You will get the entire unedited audio and video there. Well, there were a lot of questions related to surgery and post-op complications. So these questions will be answered in the next session, as Dr. Rajiv Pachauri said. It will be on the Thursday, that is on the 11th of June. The timing we will let you know. So I'll come to Dr. Satish Jain, sir. Good evening, sir.
Good evening. Good evening, all.
Good evening.
Hi,
sir.
Manish. Good to see you. Manish, his brother. It's always a pleasure having him in the discussion.
It's an honor to be called to by you.
So, good evening, everyone, and many happy returns of the day to the big boss, Dr. Rajiv Pachauri, and big thanks to Sun Pharma. Again, a big thanks to Sun Pharma for making this happen and giving this opportunity. Thank you so much.
So, sir, you have actually answered most of them, but few points we needed more clarification. There were more doubts in few points. So I'll just focus on those few points. So first I'll start with, there were many questions about the use of steroid spray and when to irrigate. If you can just tell us more about that.
Okay, I think that was discussed that day as well. There was a confusion when to use steroid spray, when to use irrigation.
Yes.
Things is, it's simple. You can understand easily. Nasal sprays, whatever you use, they do not penetrate beyond anterior 1/3 of the nasal cavity. Overall, what we discussed, steroid is the answer and topicals are safe. So, in an unoperated situation, obviously nasal spray is the only thing we can give. In the operated situation, what surgery gives us the opportunity for the locals to penetrate deep into the sinuses, and then actually is the role of irrigation, not the nasal spray. So in post-operative situation, it is the steroid irrigations which are more useful. They reach right onto the sinus mucosa in the depth of all sinuses. There is no point in using nasal sprays in the post-op period. Unless and until we don't open the sinuses, the nasal sprays are the only answer.
Okay. And so we have not as well discussed about the technique, how to use nasal spray, the preparation, the dosage. Can you explain the technique?
Yes, that is important. If you ask me, and that we have to explain every patient. Sometimes patients come to us with a sprays they are using not in the proper way, I would say. So what the nasal sprays? There are steroids, and we want the steroid to go to the inferior turbinate where they reach actually. So we need to instruct patient for the crossover technique to spray the nose. Like suppose if I'm spraying my left nose, the right nose, I should instruct patient to spray from the left end, so it should go laterally. If I'm spraying my left nose, I should ask my patient to spray to the right end, so it should go laterally. It should not go into the nasal septum to create a raw area and bleeding, excoriation, and all those things. We need the spray to come into effect to go right to the inferior turbinate. So technique is important. Once you use the nasal spray, it should go into the lateral wall, not on the nasal septum.
Okay, sir. And sir, can you tell us about the method of amphotericin administration? You had told us the dosage the other day, but there were many queries on the method of administration.
I think we discussed this thing that day. Okay, again, amphotericin, as we all know, is a drug of choice for the mucormycosis, and the administration technique is very important. Even a slightest mistake in this administration technique can lead to overall failure, because this powder of the amphotericin should not result in agglutination. So the point number one, we have to make a solution with a concentration of 1 milligram per ml, finally. And we should not use normal saline at all. Normal saline results into agglutination as it comes in contact with the amphotericin B. So the simplest way, if you are using in your inpatient department, the amphotericin solution, mostly we use liposomal. So every vial of the liposomal contains 50 milligram. As I said, for the adult, we need to have need to be giving in a dosage schedule of 3 to 5 milligram per day. Suppose you are giving 4 milligram per day, 200 milligram or 250 milligram in an adult. We need 5 vials of 50 milligram. So every 50 milligram powder, what we need to do, we have to mix 12.5 ml of distilled water. So, and mix it thoroughly with the powder until it completely disappears. There should not be any particle remaining. And it should be pure distilled water with a fresh syringe. So all those bottles should be prepared with the distilled water, and that would be 4 milligram per ml. Now, because 50 milligram is divided into, diluted by 4 times to that level, that 4 milligram per ml, because we diluted 12.5 ml into that. Now, that entire 5 bottles again should be mixed together to infuse with either a normal distilled water, or you can use a 5% dextrose as well, because these patients are diabetic, then you have to neutralize with the insulin. But every time you have to use new syringe, line should be pure distilled water, and finally again dilute 4 times. So like 5 bottles, 12.5 ml each. Now we have to mix in a 200 and 240 ml of normal distilled water or 5% dextrose to bring this to the level of 1 milligram per ml. That has infused over the period of 1 to 2 hours. That should how it should be given.
Okay, sir.
This is for liposomal, not for the regular conventional one, which is less and less being used because of the side effect profile. Liposomal is pretty safe, and you can use even higher doses of liposomal once it is administered safe.
Okay, sir. Okay, sir. Thank you. So there's a question from Dr. Gautam Khan from Guwahati. He was asking that can we predict improvement of olfaction before we start treatment based on workup?
Yes, it's a very practical question, Gautam sir. Actually, olfaction is something what he has asked is the patient asks us. Many of the patients, when they lose in olfaction with the polyposis, they come when they are advised surgery. Will I get my smell back? And you don't have an answer. What you can predict? See, first we have to understand how the smell goes. See, in order to smell anything, the air what we inhale should reach the olfactory receptors. And from there, the nerve transmit to the olfactory center. So it's like hearing. There are 2 types of olfaction loss: conductive and sensory neural. If because of the polypoidal mass air is not reaching to the olfactory cleft, how will the patient have the sense of smell? So that is a conductive hearing loss. And because of, since it is an inflammatory disease and that inflammation go into the surrounding olfactory mucosa to lead a sort of sensory kind of a olfaction loss. So in any given situation, you can try a course of oral steroids for a few days, for a 7-10 days, 2 weeks, and once the polyp regress, inflammation regresses, and patient if it starts improving the smell, then you can predict that your surgery will really help it. You can give an overall idea, but during surgery also you have to be careful, because our goal is to treat the inflammatory disease of the sinuses. We have to be very, very careful while dealing with the olfactory cleft. Even if there are some polyps, you can leave them, shave them off without damaging the olfactory mucosa at all. And once you take care in the post-op period with the steroid, it can easily take care of the residual disease. So overall, we have to preserve the olfactory mucosa. That's how you can predict as well.
Okay, sir. So you had covered quite a lot about AERD, but so there were many questions related to it. So can you just throw us some more light on this topic, AERD? Something which you have not covered that day.
Okay. Though we discussed that day, just to recapitulate, as I said, sinusitis is not a single spectrum of disease. It has a lot of endotypes. It is a time of precision medicine, and every endotype has a different pathophysiological process going on. Same for the AERD. The fault is lying with the patient who is reactive to COX-1 inhibitor. And in that scenario, the prostaglandins are not formed and the leukotrienes are formed in the abundance as the suppression form of the prostaglandins is gone and the lipoxygenase are activated. And leukotrienes are inflammatory and they give problems. They invite eosinophils and all those problems. So the goal of the treatment, as I told you, this is the most severe aspect of the sinusitis spectrum one can think of. Of all endotypes of sinusitis, this is the most severe kind of a disease you can think of. And in that scenario, patient present with as it is a eosinophilic disease with a high IgE, patient present with massive polyposis, obviously surgery is the answer. Unlike any other polyps, if you do a full house fast or anything, it works. But unless and until you reverse the underlying pathophysiology, it is bound to come back.
Okay.
That is the thing that needs to be treated at the molecular level. And for that, all these patients should be thoroughly tested for the aspirin sensitivity. You can pick up from the patient history itself. Any patient with polyposis having asthma must be screened for aspirin sensitivity, as simple as that. So
Okay.
overall, out of polyposis case, up to 10% of the patients have aspirin sensitivity. And the majority of the patients, if you elucidate the history properly, they will tell themselves, yes, they have reaction to the painkiller sometime or all this. And in any given situation, whether they give history or not, we have to confirm by means of testing. I tell you, there are a variety of tests. Oral challenge of aspirin you can give, but the oral challenge is risky. The patient may develop severe asthma or even asthma, status asthmaticus. It has been reported. So the other simple pathways are bronchial nasal challenge, if possible. Otherwise, what you can do, since the leukotriene levels are significantly increased, what we get in our practice is to get a urinary leukotriene level. LTE4, you can test urinary, and if they are raised in a patient with polyposis and asthma, it proves itself that it is AERD.
Okay.
And in that given scenario, obviously the surgical answer is same to reduce the inflammatory load. I told you that concept of inflammatory load that day. So
Yes.
you have to remove, you have to do a full house fast, do a complete surgery, and then once the healing takes place, then the patient should be subjected to aspirin desensitization. That is the only answer which can reverse the pathophysiology of the disease. Otherwise, how many times you operate? You operate 100 times, it is bound to come back again. So in that scenario, the patient has to be thoroughly counseled because that's not a simple procedure. In our series, we have a huge series of aspirin desensitization. We have to counsel patients to get admitted in the ICU setting
Yes.
under the intensivist or pulmonologist care. We have to load them 7 days before with the Montelukast to reduce the to blunt the reaction which can take place once you give the oral steroid, because you have to ultimately start with oral steroid, oral aspirin, you can say. So once the patient is admitted with all consent, we have to start with the low dose of aspirin. We start with 30 milligram. Aspirin has a beauty. Once you give 30 milligram, patient becomes refractory to further reactions for next 2-3 days. And that is how we utilize in desensitization. So once you give aspirin, the reaction is bound to take place. You can give steroid, bronchodilator, whatsoever antihistamine. Once come under control, you can keep on increasing the doses. In 2-3 days, you can take up to 600 milligram or even more. And once the patient starts tolerating aspirin, the entire thing is reversed. More prostaglandins are forming now, leukotrienes stop forming, and the entire pathology is reversed, and that is the only answer. And that's how these patients have to be maintained on aspirin for life. Obviously, we keep on reducing the doses. We need a close follow-up, but this is the only answer to treat these patients. That's why this is the time of precision medicine. We need to check what exactly the disease patient is having. It's not that all polyps, you see the patient of polyp and post for the sinus surgery without looking into what exactly it is. It can never work, or it can not always work. So that's how this is the time of precision medicine.
Satish was, can I just
Yes.
ask something here?
Yes,
Now,
Moni.
if you have taken care of aspirin hypersensitivity by this, does that ensure that there will be no recurrence now?
Less, very less. I tell you, some patients do come, even it's not problem free. You start aspirin in some patients do not tolerate. They come back, some patients develop complications. We all know the complications of aspirin or the gastric complication, bleeding, and all those issues. And some patients even do come with the disease as well. So that's why we keep them under close follow-up. Even slightest of the incidence of the disease, you have to be careful to increase either the dose of steroid, topical irrigation, or maybe you have to increase the doses of aspirin. So, but by and large, majority of the patients do very well. We have a huge chunk of patients who are absolutely disease-free now, who had been operated. I remember a patient who was operated 26 times somewhere, again and again, and this problem was not diagnosed that he was having aspirin sensitivity. So this is something we need to look at. That's why I mentioned that day, this sinus disease is not a simple disease. It's like a syndrome. We need a lot of comorbidities to improvise our results.
Okay, sir. Thank you so much, sir. This was very informative. This many of us didn't know, sir. Sir, the Dr. Shruti Bansal from Bombay did ask something about the pediatric sinusitis, but sir, we could not cover much about it. So can you just tell us more in detail about pediatric sinusitis?
Yeah, we could cover that day. Okay, can I share my PPT, 2 or 3 slides?
Yes.
Yeah, sure.
Okay. Let me. Are you getting the picture?
Yeah, we're getting. Just
Okay.
slide.
Are you getting the slide?
Yeah, getting it.
Okay. So, like adult sinusitis, there are some differences in the management as far as the pediatric patients are concerned. The reason being, there are a lot of challenges associated with the pediatric patient, but by and large, the treatment line is same. In pediatric patients, the infection rate is high. You need to be more centered over the treatment, antihistamine, topical corticosteroids, saline irrigation, and all this. All these are medical treatment. As like pediatric adult patient, the first line of management is medical management. In pediatric, majority of the focus is on the medical management, as we are reluctant doing surgery because of certain reasons, which I'm going to enumerate. Except in certain situations, like cystic fibrosis, I'll put up a slide. Just last time I forgot to mention. Yeah. Enterocoinal polyp, bilateral nasal polyposis, or fungal disease. In that situation, you have to pick up the cases for surgery without going in for all this medical management, all those protocols. Otherwise, we are generally reluctant to operate upon pediatric patients, take up for sinus surgery so easily. So, once patients who do not respond to medical treatment, saline irrigation, topical steroid, antibiotic, all those things, we have to move towards the surgery. And once it comes to surgery, the first option is not sinus surgery for the reasons I'm going to tell you. The first line option, as far as surgery is concerned, is adenoidectomy. It has been proven now. The recent meta-analysis you see published in Laryngoscope, adenoids harbor biofilms, and which have been proven to be the cause of exaggerating the sinusitis in pediatric patients. So the first line treatment, when it comes to surgical treatment, when the medical treatment fails, the adenoidectomy, along with if required enteral lavage or middle metal enterostomy. This is the first line surgical answer. The sinus surgery is the last option in the pediatric patient for the regions. See, these are the reasons why we have to think twice before doing sinus surgery on pediatric patients. In pediatric patient, the overall infection rate, overall URI, LRI is so high, sometimes reaching to the correct diagnosis is a big challenge. As I mentioned that day in the diagnostic part, once we are treating CRS, we have to have a correct diagnosis of CRS. In pediatric patients, sometimes a big challenge to reach to a correct diagnosis. And pediatric patients have a lot of associated systemic issues, immunity issues. Once it comes to operating, the development of the sinuses is so variable. You have to work in the narrow spaces. And in that situation, if you leave raw area, the possibility of synechia in the post-op is high. And complication rate is relatively high as compared to the adult patients because of all close proximity to the vital structures. And most importantly, why we are operating for sinus surgery? Because we are making topical steroid reaching deep to the sinuses, and for that irrigations are required in the post-operative period. That douching, that proper douching compliance is very poor in pediatrics. You can't expect a child to douche the nose every day, twice a day in the proper position. And once that is not done, you can't expect a good result. So in pediatric, you have to think twice before moving on to all those issues. Anything you want to know about the pediatric?
That's, I think, more than enough.
Yes, sir. I think you've covered almost everything. Sir, can you tell us more, something about the steroid eluting the role of the steroid eluting implant?
Steroid? Roll
Implants?
Propel, which we used to for the post-operative steroid stent, like Propel, which we.
Okay. Let me show you a slide that will explain you easily. Post-operative steroid stent. Okay, yes. We all know the steroid is the answer. The irrigation is the answer in the post-operative. See, what is this?
Yeah,
this spring-like material is the steroid stent. This is known as a Propel. Propel is a steroid stent, and what does it contain? This contains 370 microgram of mometazone, and it keeps on releasing mometazone for the period of 90 days. So that's how. Another point of view, post-operatively, this is a spring. It keeps open the ethmoidal axis. So for you can irrigate with the normal saline and other things later on. So this is good, but the cost is a limiting factor. This Propel costs $750 US. So in our country, it is difficult to use such kind of things on a regular basis. So this is steroid eluting stent. Now there are a lot of other stents are available. Now the new one, I forgot the name, that lasts for 6 months, which is again approved by the FDA. And the cost is again a limiting factor. It's available in India as well now.
Okay, sir. Okay, sir. Thank you. So there's a question from Dr. Kranti Bhavna from AIMS Patna. She wants to know that how many of your patients finally converted to medical treatment rather than surgery?
Yeah, that's a great question. Difficult question from Kranti. So, yes, the reason for this question is, as we always ask, to comply with the appropriate medical treatment or maximal medical treatment before switching over to the sinus surgery. I mentioned that day why we are operating. If your inflammatory load is too much to be tackled by topical steroids, you have to take a call of removing the inflammatory load so that you can switch over to the topical irrigations in the post-op period. So many of such patients with the appropriate medical treatment, like what Kranti asked, we have been able to avoid surgery, particularly non-polypoidal cases, with the advancement like macrolides. Macrolides is a wonder drug, and we have been able to avoid surgery in a chunk of non-polypoidal patients with the help of macrolides. Chunk of, not a small percentage. Over 50-60% of the non-polypoidal sinusitis patient, complete whiteout. We have been able to avoid surgery in those patients with a proper saline irrigation, underlying assessment of the immunity and the other aspects, and then topical nasal sprays and macrolides for longer periods. And this is correct. You can employ in your practice, and really you'll realize how you can avoid surgery in majority of such patients.
Okay, sir. Okay, sir.
Yes. Satish.
Yeah, boss.
Pawan Singhal is asking the role of anti-serum for Dr. Alok Bandar. Your experience with the treatment of allergic rhinitis with serum of the patient. Yeah.
Role of?
Anti-serum. Anti-serum. Anti-serum.
Serum. Anti-serum.
Okay.
I mean, for what?
It means your experience with the treatment of allergic rhinitis with serum of the patient.
We are not doing that. Any serum infusion or anything for allergic rhinitis. Yes, for allergic rhinitis, we are subjecting all those patients who are allergic to the skin prick testing and then for appropriate immunotherapy.
Okay. Dr. Narayan Jaishankar from Mumbai wants to know that when do you decide to check biomarkers like interleukin 4, 5, 13 levels? What wants you to decide if one of the Zumabs need to be used?
Question like Narayan. Yes, so that is important. That's a huge importance. When to order the testing for the interleukins in this era? We all know the biologics are going to be the future, this monoclonal antibodies. In the present scenario, the only drug which acts at every level of the cascade of sinusitis development is the steroid. In scenarios when you are treating the patient with the steroid, patient has a severe eosinophilia, I mean, beyond the, say, control IgE, polyclonal IgE expansion, not coming under control with the steroids, and you really need to look at it that what exactly is going on. The cause behind is you need to measure the interleukin level, particularly interleukin 4, 5, 13. And that's how the biologics have been introduced, though we in our country not using so far. It has been approved by the FDA, but those are the situations. In a single infusion of dupilumab, dupilumab is a monoclonal antibody against receptor 4 and 13. A single injection can revert back everything to the normal. It can reduce the eosinophilia back to normal. It can reduce the IgE back to normal. That's how it has the role. But in practical, in the clinical scenario, only in those situations, once, in spite of all your steroid treatment, the patient profile is not coming under control. In those situations, you can try.
Okay, sir. Okay, sir. So there is a question you told us about last time. You told us about the antihistaminic, which is of no much role in the chronic rhinosinusitis. But so we
Yes.
didn't discuss N-acetylcysteine and mucolytics. Dr.
Yeah, we
Sandeep
discussed.
Kumar from Delhi. No, Dr. Sandeep Kumar from Bareilly and Dr. Kusum Patidar from MP wants to know if you can just tell us more about this
Okay.
N-acetylcysteine and mucolytics.
Okay. Sandeep Boss from Bareilly and Kusu, madam. So, mucolytics, by and large, for sinusitis management, they have hardly any role. As you specifically mentioned about the N-acetylcysteine, N-acetylcysteine is a wonder drug, I tell you. It's not only mucolytic, it's an antioxidant as well. I've been using for many reasons, for secretory otitis media, and even for the sinus surgery, I have no reservation not to use. But yes, you can use, you can add on to it. It's always useful. More often nowadays, we are using it for the ear. This is a wonderful inner ear antioxidant, I tell you. N-acetylcysteine increases glutathione concentration, which is the inner ear oxidant. And we have been using this for all our patients, elderly patients, sensorineural loss patients, sudden sensorineural patients. I don't know, we are doing a study and how directly it affects, but it has got a role. In sinus disease, yes, it may soften the thick vessel secretions. It has a role. It may penetrate the antibiotics better, which is supposed to be, but it doesn't have a direct role. I don't see any direct role in sinusitis to advocate it.
Okay, sir. Okay, sir. So the next question was from Dr. Gaurav Medically from Vancouver, Canada. He wants to know about cystic fibrosis medical management.
Okay. Jinda abhi tak hai? Gaurav, cystic fibrosis. I'll take you to the slide. I think we discussed that day in a brief, and
Yes.
I told you cystic fibrosis is not so common. First of all, number two, we have seen a couple of cases in our practice. And the goal we need to understand, being ENT surgeon, first of all, we need to understand how to diagnose this, because we are the first people sometimes who come across the diagnosis. By and large, any pediatric patient, very young patient presenting with bilateral polyposis should be considered as cystic fibrosis until proved otherwise. You have to be highly suspicious about it. Cystic fibrosis in young children is common, and it has a systemic side effect because the reason is a mutation in the cystic fibrosis transmembrane conductance receptor protein gene, which encodes for the chloride channel, and mutation of which leads to the thick viscid secretions. And that's how it is diagnosed. The diagnosis clinically, first of all, like I told you, children presenting with bilateral polyposis with thick secretions with respiratory infection. The biggest issue is the respiratory infection, and ultimately they succumb to the lung infection. The goal of treatment from otolaryngologist point of view is to save the lung, to prevent infection which starts from the nose. And in that scenario, the diagnosis is important. So to confirm your diagnosis, the first test is a sweat chloride test. And you need to have enough sweat to test the chloride level. And like in the neonate, sometimes you find such patient neonates, So in neonates, like pediatricians recommend the child has to be at least 2 weeks old to give enough sweat for the testing. And if the chloride level is above 60 millimole, it is considered as a positive for cystic fibrosis. And in that scenario, once we have two children whom we operated, I can't imagine that kind of surgery we could have done in children. Bilateral complete nasalization. Because the ciliary activity is compromised, that the issue is with the viscid secretion affecting the mucociliary clearance, and you literally have to give a gravitational drainage. Nothing else is there in your hand because those retained secretion otherwise invite infection. And out of all sinusitis variants, this is the one which acquires predominantly Pseudomonas infection. Otherwise, in most of the sinusitis, it is Staph aureus, which is the main culprit. So, the, in a 3-year child, imagine bilateral complete nasalization means bilateral complete medial maxillectomies to give at gravitational drainage into the nose, bilateral complete removal of the middle turbinates, everything to give a complete nasalization for gravitational drainage, and then irrigation with a hypertonic saline topical antibiotics is the only answer. Nothing else. That's how you can prevent infection spread to the lung. The other things which are working, like you said, N-acetylcysteine being given to reduce the viscosity of the secretions. Dornase alpha alone acts in the same way. It digests the DNA of the neutrophils which are dying. And the ivacaftor is the drug which works on improving the sensitivity of this CFTR gene. So that's how a lot of research work is going on, including gene extract therapy. But so far, there is no direct answer, and the life of these patients is always not very good, as they can acquire infection anytime. And ultimately, many of these children are saved by means of lung transplantation. So our role is limited for the diagnosis and preventing lung infection.
Okay, sir. So the next question from Dr. Kaushal Sheth from Mumbai, who is our AOI secretary. He wants to know which of these monoclonal antibodies are available in India, and what is your experience in using them?
Yes, there are certain monoclonal antibodies approved by the FDA. They are being marketed in India as well. Sanofi Aventis is marketing, GSK is marketing, all those, but they are mostly being used by the pulmonologists in the severe situations of persistent severe asthmatic situations or status asthmaticus. Like I've seen using omalizumab, we have not used any time, but yes, in times to come, when the safety is established with the long-term safety, cost factor is, taken care of, because right now the cost is a limiting factor. I'm sure in the future that is going to be the main part of the treatment, not the sinus surgery. But yes, in the present situation, hardly is being used for sinusitis management. But it's available in our country. For answer, it's available in our country.
Okay, sir. So there's this question from Dr. Babak Moridi from Iran. Any role of immunotherapy for in sinusitis patients?
Okay, Dr. Babak from Iran. Immunotherapy we discussed that day. Sinusitis as such has no role. If there is associated allergic rhinitis as a comorbidity, we need to treat that to optimize our results. And for allergic rhinitis, we all know the only answer which can change the natural course of disease is the immunotherapy. That is for allergic rhinitis, not for sinusitis.
Okay, sir. So there are a lot of questions regarding IgE, like from like Dr. Gaurav Chaturvedi from Mumbai and Dr. Harshad Hussain from Bangalore. They want to know more about it, and if you can elaborate also the role of pedotomid.
Pedotimod. Really? Really?
Yeah.
So first of all, IgE. We discussed it in detail. There are a lot of implications in the management of sinusitis with the IgE. And in our, I showed in that slide, in our diagnostic protocol, IgE is always there. IgE has a significant value. In case the patient has a low IgE or normal, I would, leaving aside everything, would put patients on macrolide if that is feasible. Feasible means is no or renal or hepatic disease, not on other statins or other cardiac patients, or not an elderly patient. If it is feasible, I will put the on macrolides as a first line treatment if the IG is normal. That is important. If IG is high and if your history is giving that the patient is allergic, like dust allergy, mite allergy, whatever, then obviously you can understand there is associated allergy and that requires treatment later on with the skin prick testing and immunotherapy. If IG is disproportionately high, there are certain situations like in ARD, in AFRS, and another situation when there is Staph aureus infection. Because Staph aureus leads to polyclonal expansion of IG because of superantigens. And in that situation, you have to target with the Staph aureus directed antibiotics. So IgE governs the management the way you have to choose. The path will be chosen according to the IgE. According to these three situations, you have to take a call whether to put the patient on macrolides, whether to give an immunotherapy, whether to step treatment, or go ahead with a regular treatment. So IG is important. Regarding pedoty mode, who asked about the pedoty mode? Gaurav.
Gaurav Chaturvedi.
Pedoty mode is a wonder drug recently introduced. It was initially probably, marketed in India as Imulina.
Okay.
This drug acts at the molecular level to convert the inflammatory pathway from T helper cell 2 to T helper cell 1. See, all this eosinophilic is T helper cell 2, inviting eosinophil IG and all that.
Yes,
And
yes.
pedotimod is an immunomodulator. It works like magic to convert to T helper 1. So all those patients who have a disproportionately high IG, we should start pedotimod. And that's a wonder drug. We can give 800 milligram in adults twice a day for first 8 days and then once a day for 52 days. It's a 2 month course. We have tried in many of our patients and results are encouraging.
Okay.
Is it available?
Yes, yes. Imulina.
Imulina.
Trade name is Imulina. I don't know the other one.
It's expensive, sir?
Not really. Not really.
Okay, sir. Okay, so this is question from Dr. Rajiv Kapila, Ludhiana. He says that doing SNOT 22 I find practically not possible in clinical practice. It takes a lot of time.
Come on, Rajiv. You don't have to do anything. It is the patient who has to fill the form. It is not you who are supposed to fill. See, the value of this, when you give your patient, give him freedom to express about his problem. This is something like that. He will take the form and fill it that I have this problem of this severity. I have rhinorrhea of grade 3. I have headache of grade 2. So this is the time we should give patient to listen to him. This is simple. This is involving the patient in the treatment. And this saves you from the medical legal issues a lot. So the value is, number one, you don't have to fill. You have to give patient and patient has to fill. What you infer out of that is the patient really having symptoms of CRS, because CRS is primarily on the basis of symptomatology clinically. If the patient has irrelevant symptoms coming to you for the sinusitis management and you are biased on the basis of CT scan or something having sinus disease, you have to think twice. That's how it saves you from issues. Secondly, the same thing has to be done post-treatment as well. In the longer time after follow-up as well. Because every time you're involving patient in your management, that saves you from a lot of issues. And you, for that matter, again, Rajiv, you don't have to fill the form. It is the patient who is supposed to fill. You just have to go through it quickly, that what exactly you are treating.
In fact, it gives a better compliance. We just tell the patient come after 2 months with your form. They come regularly for 2 to 6 months, 8 months with that regular form.
Yeah, this requires long-term follow-up. Long-term follow-up.
I think one question is there from Dr. A.K. Agrawal from Kanpur. He's asking, we do frontal sinus surgery, maxillary sinus surgery. Is there a different protocol for nasal douching, and how long you recommend douching in your post-op cases with steroids or with this?
Okay. We discussed that day that douching, why douching is required. Douching is what? We are practically giving topical steroids. Now, how long the douching? How long the steroids are needed? That depends upon the patient's disease profile. I told you that day, that's why we always get the mucosal histopathology done. Histopathology will tell you how there is mucosal eosinophilia. If it is too severe, you can tell your patient beforehand, that yes, your disease profile is so much, you'll need steroid for longer and you need to take topical for longer. So that is dictated by the patient disease profile on final histopathology, which can reveal. Number one. Now the position technique, what I will do, I will take you to one slide. Let me, that will clear you how to use this. Yes. See this, these are the two positions we are training a patient. So the once we remove the pack, and the day after, once we remove the pack, we keep another day the patient in the hospital to train him what he has to do in future. So this is the head down forward position that makes the solution reaching everywhere, particularly to the olfactory recess, frontal area, everywhere, all difficult areas. You can make sure the steroid reaches everywhere. Another, this is called namaz position, prayer position, whatever you can simply call up. Another one, some patient which cannot do that because of the issues in the back, elderly patient, you can simply tell them in the lying head back position. That also allows the distribution of the drug to go everywhere. And this has been proven with the radionuclide level solutions reaching everywhere, how they are reaching to the deep into the sinuses. So these are the two positions which we advocate patient. Length of therapy depends upon the disease profile. See, in sinus disease, our counseling to the patient should be very clear. It's not the time that patient coming to you with polyps and you tell that we'll operate, you'll be all right. It's the biggest joke you can crack. We need to tell them, like what cardiologists tell patients. If the patient is stented, the cardiac stent placed, they've been explained that this to keep this stent patent, you need to take some drugs for life. Similarly, your patient needs surgery to remove the inflammatory load to make the steroid reaching everywhere to avoid the need of oral steroid in the future. But what you all need to do to ensure that you need to ensure that the topical steroid reaches everywhere for longer duration. So this irrigation is required for longer. Yes, practically what we take a call after 8 to 12 weeks, if things are absolutely okay, we keep on reducing the frequency as well as concentration and keep a close watch. We call patient every 1-2 months. If the things the mucosa is good, we can keep on further reducing. We treat the comorbidity like immunodeficiency, vitamin D, so on, all those things. If things are okay, you don't need to escalate the concentration and all that. Otherwise, you need to in that situation. So it is not hard and fast. It depends upon the profile of the patient.
Okay, sir. Okay, so there are many more questions, but I think it's a time to come to today's topic, that is radiology, because there are many questions on radiology as well. So I think we'll start with today's session.
Yeah, better to.
And the rest of the questions, we can again take up later, maybe. Or maybe if sir gives his consent, we can share your number to people.
Well, yeah, sure.
Okay, so then we'll start with today's session, that is radiology on chronic rhinosinusitis.
Okay. Is this picture coming on the screen?
Yeah, this is
Yes.
it's okay.
Okay. So today's session, what we are here for is the role of radiology in the management of sinonasal diseases. And yes, the sinusitis part I will cover in the initial first half an hour, and then move on to the further other important issues, the complex issues. So why this topic is relevant? I tell you, we all know the science is evolving, or surgical science is evolving, what we are learning from each other every day. The pace at which the radiology is growing is 100 times at the pace at which the surgery is evolving. Believe me, it's a technology, and it's a time to take the advantage of technology to improve ourselves. And that is what this is our experience, which I'm going to share with you in last 7 years, how radiology has changed the overall game for us. It has saved from so many blunders, saved from so many misdiagnoses. It is easy to do all that unless you are very, very careful, and radiology saves you from all those issues. This is what presentation is all about that. And feel free to interrupt me anytime.
Yes, sir.
The initial half an hour, I'll focus on the basics and the basic is chronic rhinosinusitis. Like Monish said in the beginning, the CT scan is important investigation for the sinusitis management. So why CT is needed? Why imaging is needed? For me, it's rarely for the diagnosis for sinusitis. Rarely. The CT scan is required solely for the surgical planning. That involves to gauge the extent of disease, kind of disease, if it is a fungus, something else, so many things you need to know. It gives anatomical details. The role of CT scan is to give more and more anatomical details, any anatomical variations, or to add on if required any image guided system or not. So radiology or the CT scan is the primary investigation to dictate further approach. That's why CT scan is required. Now, once coming to the CT scan, what all we need to see in the sinus disease? See, this is the checkpoint. This is not complete even. This is half the list of the checkpoint. In order to get the complete information what a CT can give you, you need to sit with the CT scan at least for half an hour. Believe me, it's not like physicians how they flash the ECG before them. You just flash the ECG, you get every information. CT scan is not like that. Once you're operating in the paranasal sinuses, the structures, the important vital structures are so in close proximity. In order to avoid complication, we need to have fine details of all these structures of that particular patient completely in our mind, three-dimensionally. And for that, you need to see each and everything like this. So first question, what kind of CT scan is required? So by and large, we need a non-contrast CT scan for the paranasal sinuses or the paranasal sinus for sinusitis, and we need a multi-planar CT scan. Now here, I would request everyone something which we have been experiencing for the last couple of years, how to get adequate information out of that. This paranasal sinus area, what we scan, is almost a 20 centimeter area. And we need the CT scan in all planes. 20 centimeter, fine sections like 0.5 mm sections. So 20 centimeter is 200 millimeter. 0.5 mm section, how many slices required? 400. 400 slices in axial, 400 in sagittal, and 400 in coronal. How many? 1200. 1200 in bone window setting, 1200 in soft tissue window setting. How many? 2400 slices. And if the patient is given a printout out of that, he has to literally carry a huge bag to carry the scans. Otherwise, we will not have complete information. And what generally is given? Patient is given a printout of 1 or 2 scans. That is never an adequate information. And that to whatever it is, that is not dynamic information, which we need to have, which can help us plan our surgery. So what I will tell you, show you here, just a minute, I'll share how to see our CT scan. Yes. Are you getting the CT picture?
Wait, yeah, now getting.
You're getting the CT picture?
Yeah, we're getting now.
Okay. So this is how we should order a CT scan. 0.5 mm scans. All places we will reconstruct. CT is something we can reconstruct. You cannot reconstruct MRI. MRI has to be shot in every plane separately. CT has to be shot in the axial plane and then you can reconstruct yourself. So what we order in our practice now, we order a CT scan 0.5 mm sections in DVD. And then this software you can download from the Google. This is Radiant DICOM viewer. Radiant DICOM viewer. This you can easily download from the Google. And now see the amazing details you get out of it, which you can't even think of out. So like this patient, you see here, how many slices? 376. Can you see here?
Yeah, very clearly.
376 in the axial plane. Now I will reconstruct through the help of the software. Now it is in all planes. Can you see?
Yes.
Axial, coronal, sagittal. Number one, it gives you dynamic information. It gives you three-dimensional information. Any structure you want to see, you can see in 3 planes. This is amazing teaching tool for the junior colleagues. In the medical colleges, this is amazing to teach the students how to read a CT scan in 3 planes. Number one. Number two, you can change the window setting. Like see this. This is soft tissue window. Can you see the soft tissue in picture now?
Yeah, very clear.
Intertemporal soft tissue, brain. Now I change to bone window. Again, I'm changing to bone window. See this?
Yes.
See now? All soft tissue gone, and now see the bones prominent. So you don't have to ask for anything. Once you have this software, you can check anything. Thirdly, whatever static picture you have given for a particular anatomy may not be corroborating. You need to see that particular thing in a dynamic fashion. For example, for this patient, suppose, let me enlarge this. Yeah. Is the picture good?
Yes,
Yeah,
sir.
very good, very good.
Now see, suppose I want to, it is not a static one-shot picture of the uncinate is going to give me full detail. I need to now see, focus on the uncinate. I will follow it, how it is going, how it is going up, See, it is merging with the this bullite modalis to insert on the lamina preparation laterally and giving the medial drainage to the frontal. So that dynamic information you cannot get from printout. You need to have a CT scan in a DVD form. Only thing you need to ask the radiologist is a 0.5 mm picture that they should give. Now, you can reconstruct in every plane. Any important thing you want to see, you can see in this dynamic fashion. Suppose this is sagittal plane where the frontal details are important. And see this particular cell, the agonizing cell you want to see, you can see in your surgical planning how this cell you are going to come across. Now this is the cell in the coronal plane in which we operate. This cell which was obstructing the frontal sinus, you can get to know how it is limited anteriorly. You can go behind the cell and fracture it out. So everything you need to see in dynamic fashion, and that can be gained only and only once you have a CT scan in DVD. The time has gone for the printout and ask DVDs. You can reconstruct. You can use these DVDs with your image guided systems or anything, and you can get complete dynamic information of anything you want. Okay, hope it is clear.
Yes, sir.
Yeah, very clear.
Let's get back to the slide. No. Just a moment.
What is the minimum size of cut? Means you want 0.5 mm cut because sometimes you don't get so small cuts. What is the minimum requirement for the CT cuts?
Yes, for the sinus disease, I would like to have 0.5 mm. For the otology, I would need even finer. Like for my otosclerosis patients, I'm solely getting cone-beam CT scan done, 0.1 mm sections. Before any otosclerosis, I need to have I have the complete information of the thickness of the foot plate, that my thickness is going to be 0.3 mm with cone beam, wherein you can get a 0.1 mm section. In sinus disease, 0.5 mm is adequate. You don't miss any critical structure. For example, you want to see the course of anterethmoidal artery, which has a diameter of say 0.9 mm. If you are having a bigger section, 2 mm, 3 mm, you can jump and you can miss the structure. So 0.5 mm is adequate in the sinus disease. You don't need to go finer than 0.5 mm in sinus disease.
Okay.
Now, with the CT scan, like I said, we need to focus on these issues, these points. Each and everything before every patient, we need to focus. Because on a slightest mistake, on the slightest ignorance, come across complications. The threshold of complication in sinus surgery is very low, as I told you, because of close proximity to the vital structure, close proximity to the orbit. See the orbit all the way in close proximity to the sinuses. See the skull base all the way. Sometimes some millimeter difference can make a lot of difference. So some of the areas I'll just touch upon in the next 5 minutes need to be thoroughly assessed on CT scan for sinus. Infundibulum. This picture is what is showing is infundibulum. This is a three-dimensional space infundibulum into which the maxillary sinus ostium opens. See that? And that has to be assessed thoroughly on CT scan. You can see the infundibulum in the coronal section, you can see in the sagittal section, and you can see the axial section. If you ask me, from surgical point of view, the uncinate is going to be, how big the uncinate is, how it is covering, how deep is the sinus. The best information of the infundibulum is gained by axial section. So, some information on CT scan is gained best from the axial section. For certain information you need sagittal, and in certain areas the coronal section gives better information, and you need to know what is to be seen in what section. So, infundibulum, like concha bullosa, all these things should be seen because this all helps in surgical planning. If your patient has a concha bullosa, this kind of concha bullosa, you need to address the turbinate as well, and that has to come on consent, come on paper, and you can counsel that patient accordingly. So everything has to be seen. Skull base. This is most important to prevent complications like CSF leak. Most important thing is turbinate. See how the turbinate goes up to insert on the cribriform at the junction of medial and lamella. In every patient, we need to see how the configuration is, how the turbinate is going up, how the turbinate, whether it is fragile. See that's what the Kiros classification is, very clinical one. How the olfactory fossa, this is not very deep. If you are walking in the frontal recess with a thin plate in close proximity, you can always hit and give a CSF leak. So you have to be careful. These are certain areas which I'm pointing out has to be seen in every patient thoroughly. If you don't see the entire CT scan thoroughly, at least these areas need to be seen. I mentioned about uncinate. This drainage pathway has to be seen thoroughly on a dynamic CT scan, how the uncinate is going laterally, how the uncinate is going up onto the skull base medially, so how the drainage pathway. I've seen a junior colleague, while removing the uncinate, given a CSF leak, ignoring where the uncinate was going. See, imagine how you can tolerate such a complication, and these are all preventable. So each and everything is important.
Yes, sir. So can you once again repeat the name of the app?
Radiant.
The software?
Radiant DICOM Viewer.
Okay.
RADIANT, Radiant DICOM Viewer.
Okay.
Yes, you can easily download from Google.
DICOM, DICOM.
Yes. Sagittal has significance in certain areas, and we all know for the frontal sinus, it has an immense role. And frontal sinus is always considered for the surgeon a challenging thing because of its strategic location, need to use angle instruments, so many things, and that further complicated by variety of cells in the region of the frontal outflow. So this frontal recess area has to be thoroughly seen on the sagittal scan. Three-dimensionally, dynamically, how the cell, if there is a, suppose agarnase, how it is from anterior to posterior, superior to inferior extending so that you can remove it surgically. We'll see in the live surgical session on Thursday how each and every CT scan can be utilized to improve our surgical course. So for frontal recess, which is considered difficult for the surgeons, the difficulty is added on because of these variety of cells in the region of the frontal recess. These are the group of cells which are anterior to the frontal drainage pathway. And these are the group of cells which are posterior to the frontal recess pathway. So see this. This is the frontal drainage pathway, this one. This cell which is anterior to it, and this cell is posterior to it. This is the suprabular cell, and this is the agarnase cell, and how see the frontal recess, that the frontal outflow is compromised. Now, what is the difference in handling or dividing in these two categories, anterior to it or posterior to it? For the cells which are anterior to it, we can go behind and fracture them out without any issues, without any possibility of complication. But you can't afford to do that on cells which are posterior to it. If I know that cell is posterior to the front drainage pathway, then I will use a through biting to flush it with the skull base rather than trying to go behind it, breach the skull base. So that is significance. And see, these are the variety of cells in the vicinity of the frontal recess that you need to know whether they are anterior, posterior, how they are situated. Quickly, you can have a look. We have discussed this earlier also. So this is the simplest way, the agarnase we saw on the CT as well. When I run the CT scan, how the agarnase, the most anterior cell, just go and fracture and get rid of the blockage. Then the variety of frontal cell, this is type 1 cell, type 1 frontal Kuhn cell, the one cell above the agarnase. That means now in order to clean the frontal recess, you need to go behind both the cells and get them out. and widen the frontal drainage pathway. We can do that if we have that information on the sagittal plane. That cannot be gained by other sections of the CT scan. That's the Coombs classification further. It's a very clinical classification, you can say. This is type 2 cells. There are 2 cells, tier of cells above the organ AG. You need to clear all of them. So this is a clinical classification, because as you go to the type 3, type 4, the difficulty is increasing. That's why it is clinical. Type 3, once the cells is going above the beak into the frontal sinus, not completely, and the 4 either isolated or going high up. So accordingly, you need to take a call. In type 3 or 4, depending upon your experience, depending upon the anatomy of the size of the frontal sinus, equipment, instruments, you have to take a call. Sometimes you may need to do a draft procedure to expose them and completely get rid of those cells.
So, Satish, what you prefer to use this Kuhn type of cells, the type 4 cells, 1, 2, 3, 4, or
Yes.
the international frontal sinus classification from Wormald? Which do you think is more practical?
See, this is practical. Even earlier Professor Wormald himself propagated this and used this. And whatever that international classification has been given, they emphasize more on the revision situation, difficult situations. Like, according to them, the most severe frontal sinus disease is when there is scarring in the revision situation. The frontal sinus is closed off because of the previous scarring of the frontal sinus. So their concern is different. This classification is just related to the cells related to the frontal recess, frontal outflow tract. So behind bular cell, frontobular cells, I can skip all that, and supraorbital cell. But we need to be very, very sure each and every case. We'll discuss in detail in the surgical part on Thursday how to clear off all these cells. And you can clear once you have a complete information 3-dimensionally that what kind of cellularity of that particular patient has. That's how the role of CT scan is. Yes, Monish?
One question from Dr. Jain Shukla, Dr. Satish.
Yes.
We get many CT scan because we don't get proper picture because of dental filling elements. And in those cases, difficult to see from maxillary sinus and wall. What do you recommend in those cases? You ask for any MRI or what do you do? Because of dental filling.
Cone beam. That's how the cone beam has become popular.
Okay.
Yeah, because cone beam is not available. Yeah.
Cone beam, by means of using cone beam, you can avoid artifacts. That's why the dentists are using it before implants.
Yeah.
Believe me, I'm a strong supporter of cone beam for many reasons. Like I said, for the otosclerosis ear surgery, you get a 0.1 mm sections in DVD form, multiplanar, action, and that too with 17 times less radiation as compared to the multi-slice CT scans. In some of the countries even, I don't know, some areas, it has been proven to be used even for the pregnant ladies because the radiation overall dose is very, very less as compared to the multi-slice. Artifact problem can be over. The only lacuna is you can't give contrast. For sinus also, cone beam is amazing, and as compared to the multi-slice, the cost is much less.
Yeah.
A new cone beam unit you can install in say 30-35 lakhs. The cost is very less. There is no tube, no running cost, nothing. Cone beam is amazing. Only thing for our practice, our utility in ENT, we can use it only either for PNS or temporal bone, non-contrast scan. That's it. You can't use it for anything else.
Yeah.
But for that, it is amazing.
Okay. So Dr. Ishang Jaiswal from Gorakhpur wants to know what are the radiological features on a CT scan.
Yes.
Will be an indication for draft 2B and 3.
That is next.
Later. But
Okay, Shank, if he has asked, we'll discuss in detail in the live surgical session, but yes, it's important. For draft 2 and 3, you don't have to take a call in a regular way. Yes, obviously, if you have a massive frontal disease, particularly in revision situation, you can think of primarily. Otherwise, it's most of the time an intraoperative decision when you have a difficult anatomy in the frontal and a massive disease which you are not able to reach. Then you can take a call intraoperatively to convert to a draft procedure. But in a planned way, mostly in a massive disease, in revision situations, particularly in fungal disease where you need more irrigation, more surveillance, you need to call up DRAG 2 or 3 for sinusitis. DRAG 2, 3 are other more indications. For sinusitis, you have to do like that. Yes, Monish?
My point was just one. When you talk about the Kuhn's classification, it does not divide into the anterior and posterior frontal cells.
No. Anterior cells are classified by Kuhn's.
Yeah, but the International Frontal Sinus classification, which has come in, divides probably into anterior and posterior group of cells.
Yeah.
So, will that make more sense?
Yeah. Recently it was published in American, International Journal of Rhinology and Allergy, American Society Journal.
Yes.
Yeah. But see, this Kuhn's classification, what I mean to say, is a practical one. If I am given information that I am going to deal with a type 1 Kuhn cell, or if I am given information that I am going to deal with type 4 Kuhn cell, that gives me enough material to deal with. You know, how if I am doing a type 4 cell, I have to be prepared.
Okay.
So it's a clinical one in the sense it gives you the degree of difficulty one can encounter. That's the value.
Okay.
So
I think Bharti from Mysore also wants to know about the same thing, about the IFAC classification of the frontal sinus.
Just give an example. See this coronal section. This cell, hello, can you hear me?
Yeah, we can see.
Yep.
This is the coronal section, and this showing the cell in the frontal sinus floor. Again, a cell in the frontal sinus floor looks same, but they are not same. That's why this is I purposely kept to tell you the importance of sagittal section.
Can't hear you.
Some issue with the net actually.
Yeah.
So, Miss Monish, what you were saying? What is your classification? The frontal cells classification.
Actually, as Dr. Bharti was mentioning, there is a new classification which I think came out in 2016 or 17, which was the International Frontal Sinus Anatomy classification, and that divides these cells into the anterior and posterior group of cells, right? So that is a different suprabular cells and supraorbital cells. They actually take in different configurations. So I think what Dr. Satish Jain sir was mentioning initially was right. You can the anterior group of cells you can easily remove. You can fracture them from posterior to anterior and open the frontal recess. While the posterior group of cells you would not like to do so because they are attached to the skull base, right? And that's why they have divided this into these various. I think there are 8 or 9. I don't really remember it exactly right now, but they make quite a lot of sense. But obviously Kuhn's has been followed for a huge number of years, and that's why probably we still continue to use it. But I think with time, this international frontal sinus classification, for me, it at least seems more practical and would change the things as the years go by. And that is again by Wormald and his colleagues. So I don't remember all the authors in that, but that's something which was actually, it's pretty interesting to read. I mean, we can actually try to share that if possible. Yeah, Satish was back. So
yes, dear, it was a internet disconnection. Can you hear me now?
Yeah.
Yes.
Yeah. So what I was trying to say, if you don't have this information of the frontal recess cellularity completely three-dimensional in your mind before tackling the issue, either you'll end up leaving the cells behind or you will leave the scarring behind, and both are detrimental. And according to the International Frontal Sinus Classification, that is grade 4. If you leave scarring and lead to stenosis of the frontal sinus, that is most difficult to deal with. And actually, it is most difficult to deal with. So, this is important. Again, there are some more important things about the maxillary sinus. It's not the difficulties are always with the frontal sinus only. Sometimes if you ignore this kind of a maxillary sinus, you can land up in the orbit at the beginning of the surgery. It is hypoplastic maxillary sinus bringing the uncinate far laterally close to the orbit. The moment you are doing uncinectomy, you can be in the orbit at the beginning of the surgery. And at the beginning, if you are in the orbit, that can the temperament you can have that time can affect the entire surgery. So you have to be careful, go through the radiology. Maxillary also need to be taken care of many a time with all the issues. And another important issue with the maxillary sinus is Heller cell. We have seen in revision, we do a lot of revisions, Heller being the cause of many failures in the maxillary sinus. See, this is the simplest of the Heller cell. What all you need to do is remove this party wall to communicate with the frontal sinus itself. Now, sometimes you have a multiple or bigger Heller cell. Don't ignore that because it narrows, compromises the frontal, the maxillary sinus outflow. But sometimes, imagine this, or even bigger, we have seen the Heller cell, even bigger than the maxillary sinus, appear like a maxillary sinus itself. So be careful, go through the CT scan properly, three-dimensionally. That will tell you where exactly the Heller is and how to reach to the party wall to remove it. So everything is important. We discussed last time about the
Yes.
osteitis, the implication.
Yes.
Osteitis is one of the most severe aspects of the disease, which is actually the depot of cytokines,
Yes.
where the inflammation has gone into the bone, has to be dealt with very effectively. And in such picture, the counseling is altogether different. As the patient, like you asked, how long the irrigation will be required in this patient, I would say in the beginning lifetime, because it's the most severe aspect of the inflammation to begin with. Ethmoidal arteries, people a lot of discuss about, they have importance. They need to be seen. If you have a fine section, you can see how they leave the orbit and enter the cranial cavity, orbitocranial canal. On a fine section, you can easily pick up. The idea is to avoid injury to these vessels particularly. And if you are, my bottom line is, if you are not able to identify the vessel at any point of time on working in that region, stay in the middle of the course of this orbitocranial canal, not laterally, not medially. So even if you injure the vessel, you can bipolarize it to handle it, the bleeding. If you work at the extremes, medially or laterally, you can end up in a bigger complication like orbital hematoma or CSF leak or something. So be careful. Ethmoidal arteries you can pick up, save. This is another situation. Quickly, just touching upon the important issue, the ONOD cell. ONOD is what? See this ethmoidal cell, post-ethmoidal cell is growing above the sphenoid. So what you see in the sphenoid in the coronal section, this above this is the horizontal septa, and above one is the ONOD. So what happens with that? See the sphenoid is pushed medially, and the sphenoidal cell is above, and the optic now, which is supposed to lie in the lateral wall of the sphenoid, is lying in the lateral wall of the ONOD. If you are not aware of this, and while doing post-ethmoidectomy, keep going behind without realizing there is ONOD cell, you can easily damage the optic. Now, that is something you need to look at the radiology to avoid such a disaster, I would say.
Okay.
And lastly, about the sphenoid sinus. Sphenoid is the key sinus, is the center of universe for the skull-base surgery. For sinusitis, this is the sinus, if not dealt with carefully, can invite some hilarious complications, I would say, because the certain structures in close proximity, the sphenoid sinus. See the sphenoid bone. This bone lying in the center of the skull, the one of the most complex bone, with so many neurovascular structures in close proximity. In this endoscopic picture, the carotid artery, optic nerve, sometimes even they are dehiscent, and you're dealing with that area for a non-inflammatory, the inflammatory disease, not a malignant disease. You have to be staying very, very careful, not to be going towards the critical areas, and work carefully and take care of certain anatomical variation if they are, like any of the septa going to the carotid, over pneumatization exposing the nerves and vessels. You have to be very, very careful using sharp instruments into the sphenoid sinus. And lastly, about the image guided, which is important in certain cases, not in all. I've been using image guided system since 2007. But believe me, need, if you ask me practically, is once in 3 months. Your own anatomical knowledge is most important, but yes, in certain areas, psych in multiple revisions, when disease is in close proximity to the critical areas, this can be a life-saving thing. It can be very useful, helping you removing your disease completely to do a complete job. Otherwise, you can leave the disease along the critical areas and come out. So this is important to understand. So that was about the CT scan in simple chronic rhinosinusitis perspective.
So, Dr. Sanjeev Golhar from Nagpur is asking how to recognize a suprabular cell. Can you just
Suprabular cell, yes, suprabular cell is lying along the skull base. In the posterior wall of the frontal outflow, frontal recess, on the posterior wall, you can easily discriminate with a sagittal section. That's why I told you for frontal recess, sagittal section is must. And once there is a suprabular cell, it can compromise the frontal outflow. And in that situation, you have to use a through biting or some sharp instrument to flush the cell partition with the skull base rather than pulling it out so that you can widen the frontal outflow. Suprabular, yes.
Sorry. One practical question by Dr. Sarad Agrawal from Magra. We see many cases with hypoplastic sinuses on CT scan. Any correlation between hypoplastic sinuses and future sinusitis or any associated sinusitis and hypoplastic cells or sinuses?
No, sinusitis disease has nothing to do with the hypoplasticity, but once it is hypoplastic, you have to be careful as you may invite complication if you ignore. So like I told you, in the maxillary sinus, if you ignore the hypoplastic, you can enter into the orbit easily. In sphenoid, in sinusitis point of view, you are blessed with a hypoplastic sinus. But in a skull base, if you are doing skull base surgery, endoscopic hypoplastic is a big challenge. It's one of the relative contraindications. In this, there are not one, because you can use image guided and still away, but it's a lot difficult.
Sir, can you explain the frontal drainage pathway in the sagittal section? Dr. Prasad Kelkar is requesting from Solapur.
Yes. Let me go back to the CT scan to tell you why I was saying so. Yes. Now see, are you getting the picture?
Not yet.
No, not of the CT scan. No.
Not? Okay. Just a moment. Now?
Wait, yeah. Now it's it.
Now are you getting?
Yeah, getting.
Yes.
Now see the sagittal section. What you can do, run the sagittal section to see the cellularity, how the frontal is draining. See this? This is the frontal sinus outflow. This is your Agarneji cell. This is the simplest one. If there is a cell above that to compromise that, then it is difficult. This is the simplest one. Just remove the Agarneji and the whole pathway will open up. You have to drain this frontal outflow below the level of the beak. You don't have to go above the level of the beak right into the sinus in every case. Only if the cell is going up in the sinus, then you have to go up in the sinus to deal with that. Otherwise, you have to clear the outflow without giving scarring in this region. That is the whole game about understanding the frontal sinus surgery.
Okay, got it.
And sir, how do you identify side in the sagittal section? Dr. Sanjeev Golhar is asking.
Side with a okay. Let me go back to that. Side, you have to keep all the three sections ready. See this?
Yeah.
Let me tell you. Let me reconstruct. Yes. Are you getting the picture?
Yeah.
Yes.
See this. Now, let me come to the frontal sinus. First, keep an eye on the coronal section. Can you keep an eye on the coronal section?
Yes.
Yeah. Now, see, this is the right-sided frontal sinus. So now, where you are looking at? Right frontal outflow. Can you see?
Yes.
Yeah.
Now, if I am going to the left, this is what? Left-sided?
Yes.
Yeah.
So you have to keep the three-dimensional in view. That's the beauty of dynamic evaluation of CT scan on DVD, that you can keep all the sections in view together. Is that clear?
Yeah, I got it.
Okay, sir. And so when to do contrast? In CT or MRI, will you advise doing contrast? Dr. Udbhav from Buldaneshwar is asking.
Yes. Look at this slide, the role of MRI. Contrast is not needed for the inflammatory disease of paranasal sinuses by and large. But yes, if you have a suspicion of a tumor, suspicion of a complication, then you can ask for a contrast for a MRI. That is the indication for MRI. MRI is generally not needed for sinusitis. But once you have a doubt of disease going beyond the confines of paranasal sinuses to the orbit of skull base, you have a doubt on the diagnosis. You have immunocompromised patients. Be careful about those patients because whatever you see on CT scan doesn't give details of the soft tissues. You can miss and then you can get a surprise intraoperatively. The disease is going beyond what you had thought of. So immunocompromised patient must get MRI. Patient with irrelevant complaints, irrelevant headache, orbital pain, evaluate with MRI before taking up for surgery and obviously for complications. That's how the role of MRI as well. And MRI, now, since until now we discussed about the CT scan, it looks like CT is everything as far as the radiology is concerned. Believe me, in this era, CT, the role of CT scan in our practice is less than 10%. It is the MRI, MRI, and MRI, which gives amazing, immense information. By means of MRI, you can get more than 1500 sequences. Every sequence has a value in giving some or other information. It is so versatile. CT is limited in giving details of bony anatomy. That's it. For rest, it is MRI. That's what my next part of the presentation is, how MRI can be game-changing now in our routine practice. This is very, very clinical. This is our own observation now, what I'm sharing with you. See this example of this CT scan. What do you see this? Sphenoid disease with bony destruction all around.
Yeah.
If you get a patient with a headache with this kind of CT scan, plain CT scan, it looks like frightening that this could be a tumor, isn't it?
Yes.
Yeah.
Now get an MRI done. What is this? T2 weighted MRI. This is just simple mucocele, which because of the expansion has given bone destruction. So the answer is so simple, you have to drain it and widen it. That's it. The simplest of the solution you can do in 10 minutes. With the CT scan alone, it looks so frightening. So the role of the MRI is to give soft tissue details so that you can actually know what exactly the pathology is. This is just an example. For example, here again, with CT scan, this looks like a tumor. Now, if you deal with the situation, you don't know how much it is extending, what is tumor, what is secretion. If you have an MRI, this is again a T2 weighted MRI. How you can appreciate? I told you there are more than 1500 sequences a MRI can give. With this T2 weighted, where the CSF has a bright appearance, a plain fluid has a bright appearance. What is this? This is tumor, and this is the retained secretion in the sinus. And now you can plan your resection much better. You know your margins, boundaries of the tumor, which you cannot appreciate on CT scan. Okay? So that's another utility of the MRI to differentiate between tumor and secretion. All these are required. Many a times we face so much a problem, patients refer to us with a CT scan already in hand, showing some tumor. You can't operate on that. I'm giving you many of such examples how you can easily mislead to a wrong diagnosis. So now in this next section, what I'm starting with a fungal disease, one of the most common pathologies we encounter in our practice, and see how radiology can be game-changing, life-saving, I would say, in certain situations. So fungal, we'll see one by one all. It's amazing how the radiology is important in this issue. Now it is the main discussion. It starts after the plain sinusitis. So fungal disease, by and large, either it is invasive or non-invasive. We divide into invasive, either acute fulminating or chronic one, or non-invasive, like we discussed that day. Either it is a fungal ball or allergy fungal. See, all this is, you need to know the spectrum of disease according to the immune response of the patient. Why I am saying so? Fungal ball is what? Fungus is ubiquitous in the air we are exposed to. So once we inhale, the fungus we always inhale, it is our nasal, sinonasal immunity which expels down it into the, by means of mucociliary clearance into the nasopharynx and then to the gut. If that fungus piece, because of the impaired mucociliary clearance, happens to get stuck in the nasal cavity on the surface of the mucosa, surface of the mucus, or happens to get trapped into the sinus, without any host reaction, without any immune reaction of the patient, the fungus keeps on growing, and that is known as fungal ball. Fungal ball means no immune reaction of the patient. Now, if that fungus gets trapped and patient is reactive to the fungus, hypersensitive to the fungus, then the host immune reaction comes into the action, and then the eosinophilic reaction, that's a type 1 hypersensitivity reaction, takes place, and that eosinophil secreted around the material, and that leads to the situation of allergic fungal sinusitis. The sinus gets blocked, irreversible phenomena happens. That is type 1 hypersensitivity. The difference is here the host immune reaction is coming to the role. The third variety is, but in the second variety, the immune reaction is overreacting. In the third variety is the immune suppression. You get the fungus got trapped, multiplying in your body is allowing it to, as your immune system is not able to handle that, and that happens to invade inside the mucosa. So that's how the fungal disease is classified. How they go, there's the same spectrum of the fungus, but it reacts differently in different patients. Now, radiologically, this picture is so simple. Everybody can say this is allergic fungal sinusitis. Okay?
Yeah.
And we all know this is non-invasive. In spite of so much of bone destruction, expansion going out of the sinus, it is still non-invasive. What's my point?
Yes.
Now, what is this? The sinus is very small. The sinus disease is very small. And going out of the sinus. What's my point?
Yes.
And the extra sinus component is much bigger than the sinus. This is chronic invasive fungus. See this. The extra sinus component is completely occupying the orbital apex, and a minimal sinus disease with a bone erosion in vicinity. That is chronic invasive fungus. The difference in these two entities is how you can identify separately pre-operatively in radiology. This information is vital. First of all, why vital? Why to differentiate? Because allergic fungal sinusitis is a non-invasive disease. That's a type 1 hypersensitivity. The treatment of that is a full house fast and remove the fungal antigen completely, and then follow with the steroid treatment, which is the treatment for any type 1 hypersensitivity reaction. They don't need antifungal at all. Allergic fungal sinusitis. For chronic invasive fungus, the difference is the treatment is not surgery. The role of surgery is limited to confirm the diagnosis. And the treatment is antifungal, that is voriconazole. See the game changing. On pre-operative radiology, if you are not able to differentiate into invasive and non-invasive, you cannot expect a good outcome. As simple as that. So the difference is, again, this example. This is a minimal maxillary sinusitis, bone erosion in the vicinity, and maximal extra sinus disease in the orbit. This is chronic invasive fungus. What I all need to do in this patient is, I need to take a biopsy to confirm the fungus. I don't need to remove the entire intraorbital component. Don't need to. My voriconazole will take care of it. Had this been allergic fungal sinusitis, the role is complete removal of the antigen to prevent further antigen-antibody reaction. I hope it is very clear why this differentiation is needed. Because the treatment is altogether different, and here comes the role of radiology. If you are not able to differentiate, you are in the wrong line of treatment. See this? Invasive fungus, more extra sinus disease into the orbit, and less sinus is not expanded. See this? Bony erosion out of the sinus, but no expansion of the sinus. Now, for example, see this patient. If I ask anybody, see there's so much of erosion of the sinus, and disease is going beyond the confines of the sinus everywhere. But mind it, this is non-invasive. This is simply because of expansion. Expansile erosion, not true invasion. Invasive and non-invasive is pertaining to invasion of the mucosa and submucosal tissues.
Okay.
This bone destruction is due to the disease, which is expansile, completely occupying the sinus, and because of the expansion eroding the surrounding bone. But this is pure non-invasive. This doesn't need any antifungal. This needs complete clearance of this fungal material, which is serving as an antigen and inciting antigen-antibody reaction. So removal of this followed by steroid treatment is the answer. In chronic invasive, just take a biopsy, confirm the diagnosis, and then if it is chronic invasive, the voriconazole is the answer. It's altogether different. What's my point? That's how this distinction is very, very important on preoperative radiology. In chronic invasive, the surgical treatment is needed only if it has additionally blocked the sinus ventilation and drainage. Then, along with the biopsy, we have to establish the ventilation and drainage of the sinus as well. Otherwise, there is hardly any role of surgery in chronic invasive fungal sinusitis. That the role is only of voriconazole.
Okay, sir. Sir, how effective is itraconazole when compared to voriconazole? Your experience?
For chronic invasive aspergillosis, voriconazole is the drug of choice, not itraconazole. Voriconazole is drug of choice for chronic invasive fungus, that is aspergillus. And for such patients, if there is chronic invasive fungus, you are in a great suspicion, you are not able to confirm, and you want to start treatment, additionally, what you can take the help of serum galactomannan test. Galactomannan is a fungal antigen. You can get a simple blood test galactomannan. If it is raised beyond 0.5, it is almost always indicative of the fungal disease. Almost, not always. Sometimes it falls positive also in renal disease and all. But mostly, in a high suspicion, if the galactomannan is positive, you are not able to prove histologically. You can start at least antifungal for the time being until you reach the final conclusion. So that is how you need to differentiate into invasive and non-invasive fungal disease on the basis of radiology. And this is game changing. Many a time, such patients are treated on the line of invasive fungus, such patients treated on the line of allergic fungal sinusitis, and then you can't expect a good outcome. Because for allergic, removal of the antigen and steroid is the answer. For invasive, voriconazole is the answer. Surgery has no role except proving with the biopsy. That's it.
Yeah, one question regarding this voriconazole from Dr. Rajesh Jain. How long we can give voriconazole?
What?
Voriconazole, how long we can give it?
Voriconazole doses?
Yeah, doses and how long we can give it? How many months?
How long? Yes. The end point of the therapy is difficult to ascertain, but yes, I tell you, we monitor always with the ESR. ESR is the answer, and second is galactomannan. If your galactomannan is rising, your voriconazole is not working. Fungal load is increasing. Or if your ESR is not coming down, that means still the disease is aggressive, not coming down. So what we monitor all this with the ESR and if required galactomannan. 3 months is minimum. After 3 months, we get ESR. If it has come down, clinically, the patient is fine, endoscopically fine, and biochemically with the ESR is normal, you can taper off. That's it, or switch off. But if the ESR is persistently elevated, that means sometimes you have to continue even more than a year.
Okay.
Now, the next part for the fungus. See this example I am giving you. This is a plain CT scan. The patient has a maxillary sinus disease. Can you see this?
Yeah, yeah.
Hello?
Yes, yes.
Yeah, we can see.
So on a plain CT scan, there is a maxillary sinus disease. We don't know whether it is fungus or not. How to ascertain? Now I'll give you the picture of MRI. This is T2 weighted MRI. On T2 weighted MRI, what you see, the mucosal lining, hyper intense, and there is nothing in the center dark. It looks like simple mucosal inflammation and air in the center. It looks like. Now what is there? This is T1 weighted. T2 weighted absolutely dark. And T1 weighted hyper intense. That is 100% fungus.
Yeah.
Because on T2 weighted, all these ferromagnetic components, the dark appearance, and fungus because of the inherent manganese, calcium, and the iron component, it gives hyper intense signal on T1. So in suppose, why I'm showing this? Suppose you have an MRI only. Showing this picture, this will show that there is air in the sinus and minimal enhancement of the mucosa. There is nothing else. If you have only T2 weighted MRI. But if you have both T1 and T2, you can 100% confirm that this is fungus. So you have to be very careful. All sequences of MRI, when to use what sequence is important. Why I put up this purposely? There is a big gap among radiologists and surgeons. I tell you. I start with the initial description of the paranasal sinus CT scan. Why we emphasize on reading the CT scan ourselves? The reason is, if you write a CT scan PNS and rely on the report of the radiologist, what he will write? There is a bilateral pan ossification of the sinus suggests your pansinusitis. How that is useful to you? We all know that. That is pansinusitis. What all we need is anatomical details, which radiologists are really not well versed with in the sinuses. We tried to overcome this and gave a radiologist a pro forma to fill up each and everything. There were more than 300 points. How the lamella is, lateral lamella is, how the onodicell, how this lateral lamella, this septum terminate, this, that, 300 points. Radiologist on the third day, he refused. Doc, we cannot do this. You better get someone else to do this. We cannot. This requires hours and hours of time to fill all that. And that too is not practical because it doesn't have the details of the clinical details of the patient. So onus is on the surgeon to know how to read the CT scan and get the complete anatomical details. Because you cannot rely on the radiologist's information regarding the CT scan of paranasal sinus. I hope you got my point.
Yes.
Yes,
Sir.
yes.
Same here is on the MRI. MRI is even worse. The reason is MRI, it is the onus on the surgeon to order what sequences are to be done. What's my point?
Yes, sir.
Suppose if you write MRI PNS, and it goes to a radiology center, he will finish off in 5 minutes and send back the patient in 2,000 rupees. What he will do? He will take one T1 section, axial, sagittal, whatever, 1 or 2 section and done, because he has done MRI PNS. Now, in this patient, if I don't have a T1 and T2 both, I cannot reach to the final diagnosis. I told you, first of all, MRI cannot be reconstructed. In all sequences, axial, coronal, sagittal, you have to acquire separately. What sequences give what information, it is the onus on the surgeon to know. So, for my patient, if I am getting MRI, what I will write to such patient? 3 Tesla MRI PNS, T1 axial coronal sagittal, T2 axial coronal sagittal, fat suppressed axial coronal sagittal, diffusion weighted axial coronal sagittal, contrast axial coronal sagittal. You have to complete the entire page for the requisition. Otherwise, what radiologist will do? He will do a small 1 or 2 section and finish off in 5 minutes and save money. Now, what happens? Sometimes the patients fall upon you. Because I sent to some radiologist with this and he's charging 8,000 for the MRI. The patient gets done in the other center in 2,000, come one doctor, you are sending me for this for 8,000. I think you are charging some commission out of it. The MRI is getting done so easily in 2,000 rupees. Why your center is taking 8,000 rupees? Because in those sequences which I wrote, 20 sequences, it will take not less than 1.5 hours to finish off the MRI, which otherwise you can finish in 5 minutes if you don't write what sequences you need. Because MRI cannot be reconstructed. All sequences have to be acquired separately in all planes separately. So, why this presentation I am emphasizing is, on MRI, it's the onus on the surgeon that what MRI to be ordered. If you write MRI brain, the radiologist will take the advantage and do 1 or 2 sequences and write a report, MRI brain normal. Even if there is a lesion, he may easily miss it because that can be picked up on that particular sequence, which the surgeon should know. Many a time we have referred a patient with an MRI in hand. With a clinical suspicion, we know this sequence is not adequate. We have to repeat and the patient suggests that, doctor, I have already got the MRI. Why are you unnecessarily wasting our money? Because that MRI is as good as useless. You have to understand, you have to counsel your patient. And it is the onus on the surgeon to understand that what MRI sequence to be ordered. In the coming discussion, I'll tell you again and again the significance of what MRI sequence to be ordered for particular region. That's why, yeah.
So, yes, Dr. Amit Kesri from Lucknow wants to know what is the role of MRI in the frontal recess lesion?
MRI, Amit, has no role in the sinusitis. I didn't mention anywhere in the beginning. Only I told you the indication of MRI, listed 5 indications. if the disease is going beyond the confines, if there is a doubt, immunocompromised patient, doubt of tumors or any complication. For plain sinusitis, MRI is no role because MRI doesn't give bony details. MRI gives only soft tissue details. So here to differentiate between the soft tissue pathologies, soft tissue could be a secretion, soft tissue could be mucosa, soft tissue could be tumor. MRI can, with all sequences in hand, can differentiate actually. Same in the ear. For example, cholesteatoma. In the otology CSOM case, if the patient has a secretion, purulent discharge, mucoid discharge, granulation, cholesteatoma, all will appear same on CT scan, opacity. But if you take the different sequences of MRI together, contrast and diffusion will differentiate whether it is a cholesteatoma or not. Because cholesteatoma will show restriction on diffusion, while others will not. So MRI is an immense value. Now moving on to the next. Now see this. If you have an MRI only in hand sometimes, like Amit asked,
Yeah.
if you have a T2-weighted MRI showing this, you will find only minimal mucosal thickening and the sinus is clear, having air. Black is air, supposed to be air. Now see the CT scan, completely full. I am going other way around. And see on the T1, completely enhancing, this is fungus. That is the value of everything, different sequences. You have to really relate clinically to reach to the proper diagnosis. So radiology is a game-changing role. Now see this. This is a T2 weighted T1 weighted MRI showing this hyperintense. This is sinusitis patient with the sphenoid and the maxillary, some hyperintense areas. On T2 weightage, those are dark. This is fungus. So fungus can be picked up using all these sequences. See this on T1, hyperintense on MRI, and T2 absolutely disappearing. This is fungus. As simple as I am giving all these examples so that you will never forget anything enhancing on T1 but disappearing on T2 has to be fungus. In our sinusitis. Now suppose you have an MRI T2. See this. This patient, I remember, had a T2 weighted MRI and showing absolutely normal sinuses. And see on T1 all full. And this was massive. So don't rely unless you have a complete information. Otherwise, you'll be pushed to a misdiagnosis. That is the bottom line. Now I'm moving towards a life-saving thing. This has proven to be life-saving to our patients, and we have reached to a conclusion of forming some guidelines about it, about mucormycosis. Now we have a series of 37 patients after we started the MRI taking into concentration, and it's really proven to save our patient's life like anything. And believe me, in today's concern, today's era, if somebody dealing with a mucormycosis without a contrast MRI, it is as good as useless. It's playing with the life of the patient. I'm coming to the why I'm saying so this statement. See now, what is mucormycosis? We all know it's a dreaded disease which has a huge mortality. Even in the best centers in the world, in the various series, you have a 30 to 80% mortality in various series. And so far, the reason of mortality, we all know this fungus has a propensity to invade neurovascular structure, propensity to invade vessels, and a propensity to spread to the orbit and the brain, to the critical structure, and the patient die like anything. That is the reason. Now, how can radiology change the whole game? That is the main funda. How can I tell you the radiology is game changing in the mucormycosis? And to understand that, but let us know what is mucormycosis. How does it spread? So mucormycosis, what happens? It preferentially involves the vessels, enters the vessel, the fungal mass plugs the vessel, and that area of vessel is blocked and leads to necrosis. The necrosis of that particular region is the end result of blockage of the vessel. If that spread to the orbit and the skull base, this disease goes so fast that in few days can be life-threatening. So first of all, the emphasis is on early diagnosis. How can you diagnose early? Let me tell you our practice in the clinical setting. You can diagnose earliest in certain subsets of patients who are immunocompromised, like diabetics. any diabetic patient coming to you with a nasal complaint of irritation in the nose, dryness in the nose, some anesthesia in the nose, perinasal anesthesia, you must be fully suspicious of mucormycosis. That is the earliest sign. Once you put the endoscope inside, and if you find some excessive crusting in the diabetic patient, some pallor of the mucosa, some black mucosa, you touch that showing anesthesia of the mucosa, it has to be mucormycosis until proved otherwise. That is earliest to pick up. Because earlier you pick up, you can cure the patient before it spreads to the vital areas. So once you put endoscope in a diabetic patient, immunocompromised patient, and there is excessive crusting, pallor or blackness, it has to be mucormycosis. And then what you need to do is immediate biopsy of that region. We get a frozen section done, and you can find a broad accepted fungi, and that is mucormycosis. That is so clear, and you can pick up on frozen section very easily. Because once you find the mucormycosis, you have to aggressively deal it before it spreads to the vital areas. The reason is it spreads to the vessel, and whatever vessel it has blocked, it will lead to necrosis of that area. So why MRI has a role? Suppose, see this MRI on this side, left side. This patient has a black turbinate. Can you see that?
Yes.
Why so? Because this fungus blocked the vascularity of this turbinate. And this is on contrast. And no contrast is reaching to it. Once the vessel is blocked, the contrast is not going to reach. Simple. What's my point?
Yes.
And that is the area of the fungus with necrosis that has to be debrided, because if the contrast is not reaching, your antifungals are not going to reach as well. This is a medical disease for which the treatment is amphotericin. But for that amphotericin to work, it needed to be penetrated into the fungal area. Now, once the area is black where the contrast is not reaching, how the amphotericin will reach? This patient, if you keep on giving amphotericin, this will die in no time. Because from here it will spread to the orbit and skull base, to the cranial cavity, and it will die in no time. So, what does the MRI give you information? That this area is completely necrose, is full of fungus, no amphotericin is going to reach, and this has to be completely debrided. That is the role of MRI, to dictate the surgery, dictate the extent of surgery. What's my point?
Yes.
Now, some area you see in the vicinity here, it is enhancing. See the orbital floor and the orbital medial wall? Can you see this? Enhancing. That need not to be debrided. Where the contrast is reaching, your amphotericin will also reach. What's my point?
Yes.
So, wherever there is enhancing, you don't need to unnecessarily debride.
Okay.
Only the area of loss of contrast enhancement need to be debrided. And once you have debrided that area, your antifungal amphotericin will work like a magic. Now the role of MRI is to dictate you what area need to be debrided, what not to. And if that is not appropriate, you can't expect good results. So a lot of patients dying of mucormycosis is mostly because of not understanding the value of debridement. How much to debride? There is nothing to dictate how much debridement is required. Now see on the right side, all this black area has to be debrided. See the conspicuous loss of contrast enhancement.
Yes, very well.
Where the contrast is not reaching, amphotericin is not going to reach. As simple as that. Now see the next example. This I can never forget in my life. This patient had absolute normal vision and absolute normal motility of the eye, movement of the eye. Only the turbinate which had shown contrast enhancement, we didn't look into the eye carefully. There was some area of loss of contrast enhancement in the orbit in spite of having normal vision and motility of the eye. Okay? So we debrided only turbinate. Since the vision was normal, obviously how to sacrifice it? How can you take that drastic step? Day after, the patient became blind and ophthalmoplegia. Again, MRI showing complete spread of the fungus into the orbit and the orbital apex. He lost the patient. Bottom line is mucormycosis. You need to save patient. Its life is more important than the vision. If you leave any area loss of contrast enhancement, the amphotericin is not going to work, not going to reach, and the disease will spread and the patient may die in no time. So, in spite of having a normal vision and mobility of the eye, you have to take this drastic call of orbital exenteration in cases of orbital involvement. That is the lesson that we learned out of that.
Okay, sir.
See
So
this?
what is the contrast uptake? Just a minute. What is the contrast uptake in invasive aspergillus patient, in invasive and non-invasive aspergillus? Dr. Amit Keshri wants to know.
Non-invasive do not take off so fast, but yes, invasive do. And the role of MRI, contrast MRI, is to find out the necrose areas where the antifungals are not going to penetrate, whether it is aspergillosis or mucormycosis. So, in order to improvise the treatment, the effect of the drug, we need to rule out those areas where there is necrosis, where the drug is not going to reach, not going to work. And since this mucor is a fulminant one, you can't afford to take a chance. Now see this patient. Can you see this? Left side?
Yeah.
Loss of contrast enhancement to the entire anterior maxillary tissues, even to the ala, turbinate, even to the infratemporal fossa. This ala from outside appearing normal. Now, if you don't have MRI and don't exenterate dictated by MRI, one cannot give results. You can't even think of. That's why I mentioned in the beginning, if you are handling mucormycosis without a contrast MRI, it's a bloody crime. We are not doing inadequate treatment. We need to know what needs to be exenterated so our antifungals do work. If we leave the necrosis area, need the areas where the antifungal are not going to work, there is no fun in operating those areas, those patients. In spite of whatever surgery you do, they are going to die. The fungus is going to spread. So the role of MRI is to dictate what to operate, the extent of surgery, and post-surgery again immediately you get MRI done. Contrast MRI. If there is some area left behind, you can go back and remove that, rather than leaving it to spread for future. So whatever, see this patient, even the palate, everything is gone. Palate, tonsil, everything. Everything has to be removed to save the life of the patient. So the MRI has again a role of prognostication. If the fungus has involved the loss of contrast enhancement involves certain areas which cannot be debrided, those are the poor prognosis patients. What's my point? You can tell them. It's difficult to save. And this is the only way to deal mucormycosis. Rest without MRI, it is never an adequate treatment. See this? A lot of pictures where the orbit is involved. See this? And this has to be exenterated. No way. See this orbit completely gone, exit to be exenterated. No, you don't have to think twice before exenterating. You have to do same day rather than allow it to spread any time in future. See the orbit, minimal orbital involvement is an indication of exenteration in spite of a normal functioning eye to save the patient. That is the bottom line. Now, what I was saying about the prognostication. See this patient. This area you can exenterate. Okay? Now see the region of the cavernous sinus. If the fungus has gone, the loss of contrast enhancement has involved the cavernous sinus. How you can ensure a complete exenteration? The area where the critical structures are passing through the carotid artery, cranial nerves, you can't ensure a radical clearance of that area. Now these are poor prognosis patients. Better refer to one of your enemy rather than treating these patients, because they are never going to do well. You cannot ensure the antifungal working in these areas. At the same time, you have to be careful not to do over treatment. All those areas which are enhancing need not to be disturbed. Amphotericin will take care of that. Only those areas where there is loss of contrast enhancement has to be debrided. That's it. We have said in our list of 37 patients, we lost 2 patients only. And 2, now I recollect, was our mistake, not able to pick up this area of the extent of exenteration, and that was a lesson to us to save our future patients.
So patients with renal issues where the creat is high, So we will not be able to do contrast. So how will you do then these cases?
Yeah, see, not only this, these patients have a lot of issues. These are not simple patients. These are immunocompromised patients. Diabetic patients mostly have renal disease or subclinical renal disease. You know what happens? You start amphotericin, day 2 or 3, the creatinine shooting up. Earlier it was normal. Now you tell your patient your kidney is going, which was the patient is saying earlier it was normal because there was subclinical involvement. It is not able to sustain the dose of amphotericin. So you have to be prepared with all that. And sometimes you have to do all this in spite of rising creatinine. You have to do contrast MRI. You have to give amphotericin under the cover of this thing, dialysis.
Okay.
Not only that, along with the management of surgical debridement, amphotericin, the control of the underlying condition is equally important because that is the basis of this disease. In diabetes, it is the ketoacidosis, which is where the fungus is thriving. That acidic medium is the area where the fungus is thriving. So we have to correct the ketoacidosis also. We have to give iron chelators because it is a high iron load which the fungus is enjoying. Fungus is multiplying on the iron. So we have to immediately start iron chelator also. We have to give hyperbaric oxygen. All adjuvant therapy should be tried along with the treatment of the underlying disease to do an overall cure to the patient. Diabetics are overall enjoying good prognosis as compared to the other immunocompromised conditions. Like many of the patients are organ transplantees, lymphoma, leukemia, undergoing other chemotherapies, other issues. They are poor prognostic patient because their correction of the underlying problem is more difficult than correction of the diabetes mellitus.
Okay, sir.
Can we start amphotericin B with one MRI report only? Suppose
Yes. Start immediately. Plan debridement and continue post-op.
So will any bowl of nasal packing soaked with amphotericin be any good?
In such patients, there is no need of nasal packing at all, I tell you. These are all necrosed tissues. And our extent of debridement is until we get the bleeding areas. We have used the debrider in the eye, the true debridement, the name micro debrider. In the eyeball, we went in the eye and debrided the entire eyeball because that was a necro tissue with a micro debrider. Entire eyeball was debrided with a micro debrider, like that. It's all necrosed tissue.
Okay.
Monish want to say something.
Satish, do you see hyperattenuations in all forms of fungal sinusitis on a CT scan?
Heterogeneous. Not hyperattenuation, heterogeneous.
It in all the forms of fungal sinusitis?
Yes. Not all. It is like allergic fungal sinusitis is classical. Yeah. Like it is mentioned in the Bantam-Kuhn criteria.
Yeah.
In the chronic invasive fungal sinusitis, it depends upon the necrosis. If there is necrosis or not. And those hypoattenuation in a chronic invasion is a poor prognostic sign. Because in chronic invasion, for the cure, you are relying totally on the voriconazole. And for that, drug has to penetrate. If there are necrotic area, the drug is not going to work. And then you have to exenterate them. So, mostly if it is homogeneous, they have a good prognosis as compared to the hypo and hypoattenuation in the chronic invasive fungus.
What I have always wondered is if the fungus is there, why is it really not seen in all the forms of fungal sinusitis? I mean, why shouldn't chronic invasive also have similar heterogeneous densities as allergic fungal? Why is it?
Allergic fungal is a different tissue. The heterogeneity is due to the fungus and the eosinophilic material, two different things together. Allergic fungal sinusitis is what? The fungus is trapped and the body's immune reaction in terms of eosinophilia and all that is coming to reacting to that fungus, and that is collecting. That's why the heterogeneity are coming. In chronic invasive, is mostly homogeneous. I can show you the picture again. If I go back to the chronic invasive, I show you that is almost always homogeneous, and that is a good prognostic sign.
And you never see it in acute invasive.
Huh?
You never see this in acute invasive, right?
Acute invasive is a different ball game.
You will never see it there.
Yeah, acute invasive is different.
Yeah.
Let me show you.
And also, by the time you search for it, as we know, like for middle ear cholesteatomas, you will get a DW MRI.
Yeah.
But there is specific indication, when you mentioned initially that you should always mention which films, which sections do you need? So you mentioned T1 or T2.
Yeah.
Any specific use of, let's say, flare or stir in
Yes.
MRI PNS?
Yes, that's why I told you, you need to have a variety of sequences once you suspect something accordingly.
Yeah.
That's why you have to write specifically. You
Yeah.
need T1 axial coronal sagittal, T2 axial coronal sagittal.
Yeah.
Stir is what? Fat suppress. You need
Yeah.
to write stir or fat suppress axial coronal sagittal. Contrast axial coronal sagittal. DWI separately. Otherwise, the radiologists are not going to do. You write MRI PNS, they will do one or two sequence with a one or two printout. That's it, and get away out of it.
Yeah.
So it is that is the aim of this presentation, to know that it is the surgeon, onus on the part of the surgeon to prescribe that what MRI sequences are required for that particular patient. Okay?
Okay. So chronic invasive kaisa?
Yeah. I showed you. Sorry, I showed you the
So
picture.
what is the limit of debridement in fungal sinusitis? Means this mucor.
Limit of wherever is loss of contrast enhancement. Wherever is loss of contrast enhancement. See this. See this chronic invasive fungus, Manish?
Yeah.
Yeah.
Completely occupying the orbital apex with minimal ethmoidal disease, with a bone erosion, completely homogeneous material. You just need to take a biopsy from here. Proven, it is proven fungus. The moment it is proven, you don't need to remove all this. Just start voriconazole. The results are dramatic.
True.
The improvement is dramatic.
My issue is I really do not see heterogeneous densities in chronic invasive as commonly.
No, not commonly, because it depends on the necrosis. It doesn't mean that it is never seen. The heterodensities will be seen only if there are in between necrotic areas. Got my point?
Okay.
So that is not mandatory. If there are necrotic areas, you will find. And that is a good sign not to have heterodensities in chronic invasive. In homogeneous chronic invasive, the results are good because the voriconazole will work like magic. And once there are no necrotic areas. Okay. Any more questions? Or move on to the next topic? Karamita, your mic is
Mic.
Sir, I'm saying, is there any way of differentiating between the normal tissue not taking up the contrast and the pathological tissue not taking the contrast, like in the case you presented with the orbital extension?
Yes. There are certain areas in the nose. See, by and large, wherever is the inflammation, it takes up contrast. Where is increased vascularity, it takes up contrast. Like, if I take you back to the previous scan, see everywhere, the turbinates on the opposite side, look at the turbinates.
Yeah.
See, they always take up contrast. And then, see that? The mucosal lining take contrast. See that? But not all areas. So, in those areas, see the opposite side turbinate taking up normal contrast.
Yes.
But not this side. See the conspicuous difference. That's how you have to pick up. So there are certain areas they pick up contrast, and if those are showing loss of contrast enhancement, that is the suspicion of having mucormycosis. This has a predilection of involving the middle turbinate on priority. The first structure, the most common structure involved in the nose, in the mucor, is the middle turbinate. Then nasal septum, floor, and other areas, maxillary sinus, even infratemporal fossa, then further orbit and skull base, vein. So the earliest sign you get is the black middle turbinate, loss of contrast enhancement of the middle turbinate, that is known as black middle turbinate sign. And clinically, if you are suspicious, if you know this, you can pick up such patients in your OPD even early before giving complications. Because it is always always handle diabetic patients with such complaints little differently. Be conscious. Always see if there is any pallor of the mucosa, darkness of the mucosa, excessive crusting, and if it is, you can probe that area if the patient perceives pain or not. If there is anesthesia, you can take a biopsy immediately.
Okay, sir. Sir, there's a question from Dr. Atul Jain, Delhi. He wants to know that do you debride the necrosed tissue till the tissue starts bleeding in mucormycosis? Is it still holds good in the endoscopic surgery?
Yes, exactly. Otherwise, how will you ensure that the necrotic areas have been removed?
Yes, sir.
That is the best.
So what other additional treatment would you give in mucormycosis along with amphotericin?
See, amphotericin is the gold standard, and you have to give until there is a clinical resolution. And then after you have to step down, we step down to posaconazole for a few months.
Okay.
That we use as a step down therapy, not as a first line. Another drug which is not available in India has been again approved by the FDA for mucor is the isobuconazole, which is not available in India. It's very, very expensive, and that's an oral drug but not available in India.
So Dr. Vijay Choradia from Indore says that can you display a slide of advice to radiologists for CT MRI? Maybe at the end we can do that something.
Yeah, that we can
Convey my regards to sir, first of all. Good evening, sir. See, I tell you, there's a big gap that we need to bridge ourselves between the surgeon and the radiologist. The reason is radiologists are busy with their overload. They are blind with the clinical knowledge of the patient. They're least bothered about what you want unless you ask for it. And second is the business. Because the radiologist who is doing MRI will get rid of the patient in 5-10 minutes by doing 1 or 2 sequences unless you ask for it. So the answer is you have to make a team with the radiologist. That's why we made a team here. We asked the patient, convince them to get done by that particular radiologist. Not that I have some interest, but because for your interest so that I get adequate information. You have to have a licensing with one-to-one with the radiologist for that particular patient. For any slightest doubt, you discuss with the radiologist. Always mention the complete sequences that what you want in the MRI and number of sequences. If you don't write, they will never do. As simple as that. And if you have one-to-one tuning with the radiologist, even if you miss something, he will do it for you because then you are in licensing for the diagnosis together. So it is important to have a good licensing with the radiologist. That's the only solution.
So Dr. Sandeep Kumar from Bareilly wants to know that hyperattenuating areas is in which other conditions besides AFRS?
Hyperattenuating areas in the AFRS is characteristic of diagnosis of AFRS, which is one of the criteria. Now, what you want to know, I don't get still that in other conditions.
Which other conditions will
other problems like that? Double density sameness.
But see, anything if your density, see, radiology is what's showing density on a machine or that particular product. Now, in relation to the clinical detail, in relation to the extension, what exactly it is different. It's not that the radiology is diagnosing something. We are taking the help of radiology to diagnose something.
Right.
So in that particular clinical perspective, we need to ask that hyperattenuation is important for what or not. Not in general.
Okay, sir. So we can move on to the next slide.
Next slide.
Yeah.
Monish, anything else?
Sorry, I'm pretty okay. Thank you.
Okay. Then we move on to the another important clinical condition in our practice, which many a times we come across as a surprise diagnosis. See this, a non-contrast CT scan. The patient had polyps in the nose. Obviously, for a polyp, a non-contrast CT scan is warranted. And you find this kind of a picture and the patient is taken up for sinus surgery. If you are not carefully looking at the CT scan, that what you are missing, you will come across a surprise diagnosis intraoperatively. And this was a patient of inverted papilloma. The reason is, what could have prevented you from going to the misdiagnosis? See this ballooning of the middle meatus, how much the mass lesion is ballooning, and behind that is the hyperosteosis area, which is arrow, you can see. This is enough suspicion to get further study done. What further study? A contrast scan and an MRI. I'll tell you why the role of MRI. MRI is again game changing. I would never operate an inverted papilloma without MRI, even if I lose my patient. You have to know the value of MRI. That is game changing again. See another example, the same study. See the same story. Again, a surprise diagnosis. The patient had a polyposis, and see the pre-op non-contrast CT scan with this conical projection of the bone and this ballooning of the mass lesion into the node. There is enough suspicion to warrant further studies. So what happens with a tumor behind a prolapsing mucosa anteriorly like polyp on endoscopy takes you to a misdiagnosis of polyp, which is actually a pushed mucosa because of the disease behind. And in that situation, a contrast study and a MRI is warranted. I'll tell you the reason. The reason is, first of all, why? What is the significance of doing so much for inverted papillomas? Inverted papillomas are notorious to recur. We all know. Inverted papillomas are notorious to transform into malignancy in certain percentage of patients. Maybe 5 to 10, 10 to 15 in certain group, elderly, smoker, all those, whatever. But they have a tendency in certain subsets of patients to transform into malignancy. We all know. And radiology here can save you from all these problems. The reason is, this is a benign disease like any other benign tumor in the body. And for any benign tumor, what is all required is a complete radical excision of the tumor to prevent recurrence. It is never a recurrence. The so-called recurrence is always a residual tumor left behind. That's my point. And in inverted papillomas, it is the site of attachment where the residual tumor has a propensity to invade into the eversion system of the underlying bone. If we don't know that information, if we don't drill out that completely, it is likely to come back. So from radiology, what all we want? From radiology, what we want is this information where the tumor is attached to, so that we can plan a radical removal of the site of attachment. Number one. Radiology, what we expect? Yes, it is inverted papilloma. Are we dealing with something else? We should be able to reach to a correct diagnosis. A CT scan will not tell whether it is papilloma, whether it is cancer, whether it is polyp. It will not. It is just showing a opacity. So we want something more from radiology, whether to substantiate our diagnosis, whether it is a papilloma, number one. Number two, what is the site of attachment, so that accordingly we can plan a radical excision. We can plan a surgical approach accordingly, according to the site of approach. And third is whether it has already turned into a malignancy. The reason is, if for such tumor you do an endoscopic surgery and on final histopathology it turns out to be malignant, it is never an oncologically sound operation. Right. You have to again go back for a radical surgery. And that certainly can be avoided if you have a good preoperative information about any possible transformation into malignancy. Got my point?
Yes, sir.
So these three information, if you have pre-op in your hand, number one, a correct diagnosis, number two, the site of attachment, and number two, a transformation in malignancy, you can certainly optimize your results. And that's what we have, a huge series of papillomas, and 90% we are getting are revisions. You can certainly avoid that by means of having these three information in your hand, and that can be provided only and only by MRI. A CT scan will never provide all that information. Let me show you how. First of all, why so? Why I'm saying so? MRI can characterize the nature of the tumor. Inverted papilloma, as the name implies, inverted means the tumor, wherever the tumor arises, goes revert back into the stroma, reverse, inversion. So the tumor, wherever it arises, it goes back into the stroma. That is inverted. And how you can pick up on a contrast MRI or T2 weighted? Alternate bands of hyper and hypo attenuation. Hyperintense, hypointense band, alternate, and that area where they start is the site of origin. That's the first information we want, is the site of information of site of origin, number one. Alternate band of hyper and hypo attenuation. Hyper attenuation because of inflammation and hypo because of the tumor. And that is known as cerebriform convolution pattern, CCP. That is highly diagnostic of inverted papilloma. It gives us all three information. Number one, it gives us the site of origin, which we want. Now, if I know in this patient, the site of origin is in the lateral wall of the maxillary sinus. What will dictate it? It will dictate me to plan a Denker's approach to reach to that site. It will allow me to expose that area, and then I need to drill away that area completely to remove the tumor which has gone inside the bone so that I can radically remove it. If I am not able to expose the area, not able to drill, there is no fun in operating such patients. They are going to come back. So the information is where the site of origin is. Number two, it is inverted papilloma because of the CCPs. CCP will tell you that it is inverted papilloma. See another picture. See the site of origin here and how the CCP going. See the CCP. See the CCP. Let me show you another picture that will help you understanding easily. Radiology. Yes. Oh, sorry. Just a minute. Sorry. Oh, come on. Why it is not going? Just a minute. Yes. Now let me show you the inverted papilloma. Yes. See this. Are you getting the picture?
Now we're
Yes.
getting.
Are you getting? Yes.
Yeah, getting.
Now see, this is the patient of inverted papilloma. Can you see the CCP?
Yeah, very good. Very well.
See, this tumor is arising from the lateral wall of the posterior lateral wall of the maxillary sinus. Inferiorly as well, going towards the alveolus and then going into the, see the CCP going into the stroma. Can you see?
Yes.
Yeah,
This is 100% inverted papilloma. That is the kind of information you get from MRI which cannot get from CT scan. So number one, the diagnosis, correct diagnosis. Number two, the site of origin, because this is immense significance for us. This is of immense significance. The reason is now we have to plan our approach accordingly, which can give us exposure of this area to drill away completely the underlying bone until we get the normal area. See, the Krause's classification is a very practical classification in inverted papilloma. The reason being, Krause's classification shows that the type 1 medial wall maxillary sinus tumor, type 2 lateral wall superior wall, type 3 this frontal, type 4 sphenoid. Why so? It shows the degree of difficulty in eradicating the disease from the underlying bone from there. Suppose, why this is type 2 from the Krause's? Because, had the disease been there in the medial wall only, you could have removed by any endonasal approach. Had it been attached to the inferior turbinate, middle turbinate, like medial wall only anywhere, you could remove endonasal without giving by going to any expanded approach. But if it is going to this area, this is type 2, because now in order to reach that, you have to do a Denker's. You need more exposure, more difficult. So this is type. Now, had this been going to the frontal, then the skull base, the difficulty is more, because now for the axis, you may have to do some expanded approach of the frontal, or sometime going to the anterior wall, you may have to go by the open approach. The skull base, sometime you may have to remove the skull base, keeping the dura intact and remove the tumor. Sphenoid, if it is going, suppose going to the sphenoid and attached to the wall of the sphenoid, suppose posterior lateral wall, we have got some patients. Now imagine with a carotid and the optic underlying, and you have to radically remove the underlying bone to radically remove the tumor. How difficult it is. The possibility of complication. And you can thin out the bone and remove the periosteum elevator, exposing vital structure clearly, but it requires a lot of difficulty. It poses a lot of difficulty, poses a lot of challenge. So that's a clinical classification. So in MRI gives you the diagnosis, MRI gives you the site of attachment, and the third information which we wanted, let me go back. The third information which we wanted, yes, third information which you want is whether it has undergone medical transformation. Okay? How you can get?
Yes.
See, this is MRI, the CCP coming from everywhere.
Yeah.
Now see this MRI. What is this? Loss of CCP.
Okay.
Can you see this? That is quite suggestive of a malignant transformation. Now, why it has a value in radiology? You could have taken biopsy as well. But unfortunately, whatever you biopsy you take from here, you cannot pick up even if there is malignant transformation because it starts in the depth of the tumor. Even if you take multiple biopsy from the surface may turn out to be negative. Now, it has converted into malignancy. Having known with the MRI pre-operatively that could be malignant, now you are all prepared to deal with that. Now intraoperatively you can send for frozen and then take a radical oncologically sound operation maybe requiring a total maxillectomy. Or now we can do even such limited malignant transformation we can handle with the endoscopic approach also with some sort of subtotal maxillectomy endoscopically. But the bottom line is this information pre-operatively that it has undergone malignant transformation is amazingly vital.
So how do you understand this loss of CCP? Can you just explain us once again?
Yeah, see the CCP here, the linear hyper and hypointense band, and which is lost here focally. That shows the indicative of malignant transformation. So this loss of CCP showing malignant transformation, if you have beforehand, you can plan your surgical approach accordingly. You can counsel the patient accordingly. And you can carry out oncologically sound operation for the malignancy accordingly. Otherwise, you cannot optimize the treatment. You have to cut a sorry figure once the final histopathology turns out to be a malignancy, and then you again go back with a radical surgery again. You lose the trust of the patient, and it's overall.
You advise MRI for inverted papilloma even in limited disease, like suppose arising from the middle terminate or
always better. Why not to? It gives you the information which you otherwise cannot get by any other means.
Okay.
I told you in the beginning, when we started with the sinusitis, the part of the CT scan is over.
Yeah.
The value of CT scan in our practice is 10%. 90% is taken over by MRI because of the versatility of the MRI. The kind of information, the kind of the versatility it has and the information it gives is amazing. It cannot be replaced. Do we move on to further any questions?
Sir, there's a question from Nepal. Dr. Gayawali wants to know that could you please also discuss the MRI findings of the NK cell and T cell lymphoma of nose and PNS?
I will come later. I have few slides of the lymphomas.
Okay,
and to answer your question, MRI has an immense value in distinguishing benign from malignant lesions. In malignancy, the carcinomas for lymphomas, if given a good MRI to me, the sequences which I want, the diffusion and all, up to 98% sensitivity without histology, I can tell it is lymphoma or not. This much is the importance of MRI. And this has a value. This has a value particularly in the skull-based lesions. The reason is, in the deep-seated skull-based regions, it is not always so easy to take a biopsy and plan the treatment. If you have a good radiological information, you can accordingly be much more prepared to deal with the biopsy and further treatment. What's my point? Even if a massive tumor, last week we got a 2 weeks back, a 10-year-old child, complete bilateral blindness, huge lesion in the sphenoid, encasing carotid going up in the skull base, everywhere huge. Got MRI done, it was looking like a lymphoma. And they were all depressed because the doctor everywhere said that it's difficult to save this child. Once the MRI gave us the suspicion of a lymphoma, we took a biopsy, turned out to be lymphoma. Now the patient is referred for chemotherapy and hopefully he'll do well.
Okay.
So MRI can be game changing.
Okay. Dr. Prakash Munka is asking, what is the protocol for review MRI in invasive fungus or inverted papilloma when you ask to repeat the MRI?
For mucor, immediately after the exentration, first exentration. Immediately after the first exentration. For rest, once rest like papillomas or fungus and other fungus, it is once you have done endoscopic, your endoscopic surveillance is good enough. No need to, to repeat the MRI again and again, unless warranted. Papillomas, I tell you one thing, inverted papillomas. For recurrences, even before the radiology tell you recurrence, even before the radiology is able to pick up the recurrence, you have a blood test to tell you the recurrence, that is serum squamous cell carcinoma antigen. Serum squamous cell carcinoma antigen, though it is not 100% specific of papilloma, but it is quite specific and sensitive in the sense we have done in a couple of cases, and now we are switching totally onto it. In this papilloma patient, before surgery, you get serum squamous cell carcinoma antigen. It will be quite raised. Operate it and get it done after 5 days. It will come back to zero, almost. Now you monitor endoscopically this patient, and time to time, see, these recurrences can come even after the years. So up to 2 years are the maximum recurrences. So in that period of time, every 6 months, you get a serum squamous cell carcinoma antigen. If it is normal, you don't need to repeat radiology. But yes, if you find a rising titer of squamous cell carcinoma antigen, even your endoscopy is not able to identify recurrence, that warrants the radiology. That somewhere is the recurrence, somewhere it is coming back, and now it is time to pick up so that you can treat it earlier. That's the value of that test, serum squamous cell carcinoma antigen. But that is for inverted papilloma only.
Okay.
Any other question?
Sir,
You prefer only 3 Tesla MRI for these cases, or because at every place we don't have like smaller cities? Like
3 Tesla is always good with a good signal intensity ratio for discrimination as compared to 1.5. But in most of the time, 1.5 can also do. It's not that hard and fast, but it is always best to have better to have a 3 Tesla.
Okay, now next.
Sir, how to different? Dr. Rajendra Kumar from Jodhpur wants to know how to differentiate clinically polyp to inverted papilloma and get an MRI done.
Yes. So clinically, endoscopically, sometimes you find a pure polyp and difficult to differentiate, and you get a non-contrast CT scan.
Yes.
On non-contrast CT scan basis, I put up 2 CT scans to show you any hyperosteosis of the bone behind, conical projection of the bone, thin bone, erosion, whatever is a suspicion of papilloma behind. Number 1. CT can give you that much of information, nothing else. CT has no value beyond that. And clinically, if you find not pure polyps, but something mulberry type rather than a polyp, then is a suspicion to take a biopsy. Polyps are soft and smooth on surface. Those are absolutely different from papilloma. And if you're lucky to find something in the nose with no polyp onto it and direct papilloma, you can directly take a biopsy and prove it.
Okay. So there are a few more questions. Dr. Bhavik Shah from Mumbai wants to know how to find the location of attachment with the help of CCP in inverted papilloma.
Wherever the CCP is started is the attachment site of attachment. See the CCP started here, the lateral surface. See where the CCP started is the site of origin. As the CCP is what? The tumor is growing, reversing into the stroma. So the site of origin is always in the deep.
Okay.
That's why it is reversing, it is inverted. Okay. So wherever the site of origin of the CCP is the site of origin of the tumor.
Okay. Sir, Dr. Vidyasagar from Vijayawada is asking what type of cuts you take for inverted papilloma?
Hi, boss.
Or trans or T1?
Yeah. For inverted papilloma, you need T1 weighted, you need T2 weighted MRI and contrast MRI, contrast T1 weighted. The CCP are visualized on T2 weighted and contrast T1 weighted MRI. These 2 sequences for CCP.
Okay. So Dr.
And this is complete architecture what MRI depicts. The hyperattenuation is the inflammation and hypoattenuation is the tumor on T2. On contrast, the hypoattenuation is the inflammation and hyperattenuation is the tumor. It's altogether absolutely reversed on T2 and contrast.
Yes, sir. Sir, Dr. George Varghese from Kochi is asking, is inverted papilloma T2 or T1 weighted MRI is better?
Yes, boss. So as I mentioned, the T2 weighted MRI. This is T2 weighted MRI and T1 contrast. These 2 sequences are required. when you
And so,
suspect inverted papilloma.
and so
And
what?
third is, I will come to it later, the diffusion weighted imaging. That is a bioimaging, true bioimaging by MRI. That is again crucial to differentiate benign from malignant lesions. I'll come to it later. But here in papilloma is also in doubt. When you want to rule out malignancy, you can get a diffusion sequence also along.
And so what MRI sequence you need for inverted papilloma? Dr. Vidyasagar is asking.
The same T2 weighted and contrast T1.
Yes, sir. Okay, sir. Sir, I
So
think
what are protocol for asking for serum squamous cell carcinoma antigen? Means when you ask
Pre-op, and 5 days post-op.
Okay.
And then you keep an endoscopic surveillance and get after 6 months to see any subclinical disease. If it is normal, radiologically, the endoscopically it remains normal, no need. At the end of 2 years, again you can ask.
Okay. So at every 6 months interval, you were suggesting that
No, unless you are suspicious, if something is coming.
Okay, sir. So it was a very informative session. In fact, even Dr. Vijay Choradia is saying that I feel the best informative practical webinar of the lockdown till now.
Oh, thank you, sir, and thank you for being with us. He's such a senior person and giving his time to be with us. It's a pleasure.
Yes, sir. So I think we can move on to the next.
Okay, in the series of the next pathologies in the nose, we all know JNAs have their own place. JNAs are another challenging tumors. We know the challenge, what they pose is the bleeding. And the treatment, we all know, the sole treatment is surgery. Sole treatment is surgery, nothing else. And since they involve the young people, young children, young males, the primary treatment being surgery, being a benign tumor, like I said, for papillomas and other tumors, for any benign tumor, it cannot recur if it is completely removed. The same thing stands true here as well. If the tumor is completely removed, JNA, it cannot come back. But we see how notorious it is, and we come across a lot of recurrences. Those so-called recurrences are actually the tumor which was left behind. Which was left behind by the surgeons, maybe because of the lack of surgical understanding, or due to lack of understanding of the extension of the tumor on imaging. Again, here the imaging is game-changing. Imaging gives you certain information by means of which you can get to know those hidden areas which otherwise are easily overlooked.
Last time it was 1400. It was 1400 last year. 1400.
So, see this previous, the first CT scan on the left upper side. Can you see?
Yes.
That is a classical extension how the JNA grows circumferentially from the site of origin. From the pterygoid wedge, the anterior process of the pterygoid bone here. It circumferentially goes around. So, first role of radiology, the first and the foremost and the most important role of the radiology is to reach to the diagnosis. Why it is so, particularly in JNA? Because in JNA, it has a specific target population where this tumor arises, the young males. And it is almost always clinically diagnosed. This tumor is clinically diagnosed because knowing the propensity of bleeding, you never take a biopsy to prove what it is. So it is almost always diagnosed on the basis of radiology. Clinically and then substantiated by the radiology. So clinically, how you can diagnose this tumor? The reason why I'm saying is because you are not supposed to take biopsy. So clinically, any young male presenting with a nasal obstruction or history of bleeding, and you put an endoscope and a mask in the nasopharynx, is almost always a JNA until proved otherwise. It's good enough suspicion. That may not be always 100% true, but it's a good enough suspicion to diagnose JNA. The next role comes from radiology. The reason is this tumor has a characteristic pattern of spread. This tumor arises from the pterygoid wedge here, from the anterior wall of the pterygoid process, and then preferentially spread to certain areas. That is classical picture of JNA. Preferentially. Preferentially means, are you getting my cursor? Are you seeing my cursor as well?
We can see, yeah.
Cursor.
Yeah, we can see.
Okay, so this tumor arising from here preferentially spread to the posterior part of the nasal cavity and nasopharynx. It preferentially erodes the pterygoid process to enter towards the skull base. It preferentially goes out of the sphenopalatine through the pterygopalatine fossa laterally to the pterygomaxillary fissure into the infratemporal fossa. Preferentially behind the pterygoid process into the parapharyngeal space. Then from the nasopharynx or the pterygoid process, it preferentially involves the sphenoid sinus. And from there, from the orbital fissure, the inferior and superior orbital fissure, it tends to preferentially involve the cavernous sinus. From the pterygoid process erosion, it tends to go up in the temporal lobe of the brain, middle cranial fossa. These are all preferential extensions. By looking at this picture on the first left, all these four pictures in a young man presented with a bleeding with all these four pictures is good enough to diagnose JNA. Because showing all preferential extensions. So first role of radiology is the diagnosis, because you're not supposed to take biopsy. Number one. Number two, the role of MRI. There are certain areas where MRI is game changing again. What additional information does MRI give? Number one, it gives you, for diagnosis, to confirm your diagnosis, the flow voids in the tumor. Can you see the flow voids, the big vessels in the tumor?
Yes.
Dark flow voids in the tumor? That is classical of a vascular tumor, number one. Number two, it gives you, see on the contrast, it takes significant enhancement.
Yes.
Because it's a vascular tumor. Okay? Number three, on a good scan, if you have a good scan and information, proper fine scan, you can see the vessel passing through the tumor, which is the dominant vessel most of the time, internal maxillary. See the internal maxillary. That is such a vital information you get out of MRI. You cannot get on CT scan. That's my point. Can you see this vessel?
Yes.
How it is important surgically? See this example. This patient we can never forget in our life. Generally, what happens for such tumor, you have seen in live surgical sessions many a time. We go by the Denker's approach, go to the pterygopalatine fossa behind the posterior wall of the maxilla, and there we find the vessel. And we take the vessel in control and then remove the tumor. That's the main feeder.
Yes.
In this patient, see this. Where the vessel is, can you see laterally the vessel?
Yeah, very clearly.
See the level of the palate here. And see the level of the vessel is pushed so laterally and inferiorly. So we went in the pterygopalatine fossa and looking for the vessel for half an hour, we is not able to find it. It was displaced by the tumor mass itself. Can you see?
Yes, sir.
And the role of MRI is to tell you where the vessel is. You went back to the CT scan. That's why MRI. That's why all these imaging, all should be available in the OT room, your OR, for the ready reference again and again. Went back to the MRI and so found that how the vessel was displaced. Then immediately we came back, lifted off the tumor and the vessel was so obvious. See how game changing the MRI is. Third is, there are certain areas why this tumor has a propensity to recur again and again. One and only reason, if you ask me, the tumor which is left behind. One and only area where tumor is most often left behind is the pterygoid process. And in that region, unfortunately, when even you see endoscopically, you may not be able to find the lesion. It looks all normal, and still you may leave the tumor behind. What can pick up? What can pick up there? MRI. See this MRI. See this. MRI can pick up what is there in the pterygoid process. The marrow, bone marrow. bone marrow. That is, bone marrow is hyper intense. See this, bone marrow on the opposite side, hyper intense. And this pterygoid bone marrow is invaded by the tumor. The fat is replaced by the tumor on hypointense. Means, in spite of a normal looking pterygoid process, the pterygoid process is invaded by the tumor. And in that situation, knowing this information from MRI, you have to literally excentrate the pterygoid process as a whole to prevent so-called recurrence. If you don't know this information from MRI, you are likely to leave the tumor behind. See, so amazing a role of MRI. What's my point? So MRI is important for so many things. And another thing I will show you how MRI is important. Let me change to the MRI scan.
So
I will show you. Yeah.
Yeah, Miss. Yeah, why Miss? What about your the radiological classification of JNA? Or you believe in classification of JNA or no, or radiological classification of JNA?
See, you have to think on your own according to your capability of removing the tumor. Are you getting the picture?
Yeah, getting.
Yeah, what picture you are getting?
MRI, Miss. It's a
CT scan.
CT scan.
Okay. So, like you asked for the classification, see, to me, the tumor in the nose, which you can remove endoscopically, hello?
Yeah.
That is the simplest, I would say, opportunity, grade 1. Tumor going laterally, which warrants the dankers. For your experience, it is grade 2. If it is extending to the skull base, it's grade 3 because it requires a lot of other efforts. More efforts, more involvement of other specialties, and if it is going intracranial, is something which involves neurosurgical and ICU and neurointervention and so many other care. So that is the grading, so that you can plan whether you can do it or not. And if you do, what other things you require. That is simple grading. Now going to the classification to, confuse or unnecessarily complicate it, there are more than 100 classification systems existing. Everyone has their own classification. You devise tomorrow Agra classification, somebody will devise day after Jaipur classification, Delhi classification, no point. No need to unnecessarily confuse yourself. Simple grading, what you can do. If it is in the nose, you can remove endonasal, which is going laterally, you can do dankers, going to the skull base or going intracranial. Simple. Now it is you have to assess your capability whether you can remove it or not with your experience, your setup, availability of other specialties, backup, and so many things. Otherwise, there are so many classifications, grade 1A, 1B, 1C, 1D. There's nothing. There's just more to confuse you. Believe me, we have gone through all this and finally reached to this level. There is no point in getting this.
And Dr. Rajan Bhargav asking, what is the pathomorphology of its spread? The JNA spread means how and why it is spread. What is the way?
It's a tumor. It's spread by, I would say, compression. It erodes the bone, everything by means of expansion. It's a benign tumor. It's not infiltrating actually, but yes, the revision JNAs sometimes become infiltrative. Now, are you getting this MRI?
Yes.
Yeah, you're getting it.
So I was telling the value of MRI, number 1, so giving you the diagnosis with the fluoids to confirm. Number 2, the marrow involvement of the pterygoid, that is vital to know. Otherwise, if you ignore that, you are likely to leave the disease behind in the pterygoid cluster and it is going to come back. Number 3, the vascularity. Now, number 4, the intracranial extension. See this MRI. Can you see this?
Yeah.
Yes,
It is intracranial but extradural. Can you see this?
Very clear.
The clear separation, this tumor, primary tumor, however big it is, the primary tumor is almost always extradural. Primary. We have removed huge intracranial extensions, huge, but almost always extra. But revision is a different ball game. The reason being, most of the revisions, when primarily the primary blood supply is cut off, the internal maxillary in the primary surgery, and tumor extend into the skull base, they derive more and more blood supply from the internal carotid system and ultimately become more and more invasive. We have seen true cerebral invasion of a lot of JNAs in our practice, and which requires a combined approach. Now, any JNA deriving blood supply from inside the brain, never ever try to attempt from removing from below. Because if you leave any vessel retracting into the brain, it's a disaster. So in that situation, that's a watershed line. Any JNA extending to the skull base, angiography is warranted. A simple grade 1, grade 2 JNA, no need of angiography. It's not going to change the plan. Because the vascularity is almost always internal maxillary, whether to do angiography or not. Though if it is extending, it's a big one, large one, then you can plan a angiogram to know the other vessel supplying it so that you can plan accordingly. Skull base, yes, always angiogram. See this role of MRI to tell you exactly that it is extradural. Can you see very clear?
Yeah.
Yes.
Now, what you can take the advantage of it. Now, what I am taking the advantage is, see now, I will take two sequences together. The contrast, let me show you. See this is contrast and this is T2. Can you see this? Hello?
Yeah,
Yes.
we can see.
Very clearly.
On one end, this is the T2 weighted left side, and this is the contrast on the other side. Can you see very clear?
Yeah, very
Yes.
clear.
Now you see the dynamic, how the tumor is growing laterally, how it is filling the infratemporal fossa, how it is going towards the orbital apex here. See this? Orbital apex, and now it is extending into the temporal lobe of the brain from here.
Yeah.
But completely extradural. See this? Now see the another thing on MRI you need to see is that is immense value, that carries the immense value, that is involvement of the carotid artery. See this carotid?
Yes.
Looks embedded in the tumor. Can you see?
Yeah.
Yes.
See, this is the, see now on the left side, this is the cavernous portion of the carotid.
Yeah.
And see, this is the carotid, and how much of the carotid is involved? Let me take the axial. See this. Now together axial. See the value of this software. You can run all the sequences together in all planes. See now. See on axial. More than 180 degree of the vessel is involved. This is called carotid involvement. What's my point?
Yeah,
Yes.
got it.
This is decision making. If you have 180 degree carotid involvement, you need to have an angiogram before. For many reasons. Number one, in case you remove the tumor and you happen to injure the carotid, you need to have certain information beforehand. You need to have information of the cross flow at the level of circle of Willis in case the vessel is sacrificed. Or you need to have number two, you can do such cases only where the neurointervention facilities are available. So in case of any disaster, you can take the help of neurointervention to handle the carotid injury. Okay?
Yeah, I got it.
So that is dictated by a good MRI. See this? Amazing information you get by the MRI. In all three planes, you can see how the vessel is involved. See this? In the sagittal plane.
Yes.
You get to know if there are any feeders coming from the intracranial side. This is purely extradural tumor. See this?
Yes.
Purely extradural tumor. So the radiology is game changing again. It's the same thing.
And
So
what are radiological protocol for revision cases?
revision cases, always if they extend to the skull base, an angiogram and a good contrast MRI. These two things. Now see this picture of why I put up this picture. Can you see this slide?
Yes, sir.
See this, the extensive tumor. Extensive means completely occupying the nose, nasopharynx, sphenoid everywhere, completely occupying the pterygopalatine infratemporal fossa and the parapharyngeal space. And on the coronal, if you see, it was extending high up to the roof of the infratemporal fossa. What does it mean? I would definitely get an angiogram done in such a situation. For the reasons I tell you, had this not been extending so much, the feeder would have been internal maxillary only. Okay? And then you don't need an angiogram. You can intraoperatively clip the internal maxillary and remove the tumor. With this much of extension, the tumor has a feeding vessel from behind that is ascending pharyngeal.
Okay.
Tumor has a feeding vessel from the roof of the infratemporal fossa from middle meningeal. And both these vessels are behind the tumor. What's my point? The principle of endoscopic surgery in JNA is you don't deal with the tumor first, you first clamp the internal maxillary and then devascularize and remove the tumor. Okay? Now, with these two vessels behind, that is ascending pharyngeal and the middle meningeal up, which you cannot expose unless you remove the tumor. Imagine how much the bleeding would be, it will never allow you to remove the tumor. Okay? And
Yes.
this is the indication of angiogram and embolization of these vessels which are behind. In our practice, we don't get embolization done only in certain scenarios where you cannot control the vessel unless you remove the tumor. You have to get embolized, otherwise it will never allow you to remove the tumor. I hope it is clear.
Yeah.
Yes.
So this is the classical indication of embolization when you cannot control the vessel unless you remove the tumor first. And that is the indication of embolization. See the intracranial extension? Now, see such intracranial extension, you have to plan accordingly. Many of our, in our series of patients, when the carotid is completely 360 degree encased, we got the DSA done, digital subsection angiography, with a good cross flow on both sides, on the opposite side. Counseling the patient beforehand, because if we remove this tumor, this may lacerate the carotid artery and then intraoperatively can be a fatality. So in those best situations, the best thing in this situation is if you have a good cross flow, or few of those patients, we got the carotid completely coiled in that region by the intervention radiologist, completely coiled from inside and then remove the tumor without any fear of laceration. But that can be done only when there is a good cross flow. And still with the consent, because in spite of all that tests for the cross flow, there is still a 5% possibility of a stroke. I hope it is clear.
Yeah.
Yes. So, sir,
Now-
embolization will be in all cases or in grade 3 only?
No, I told you specifically, embolization is required when you cannot control the vessel first before removal of the tumor. Then you have to embolize it. In most of the cases, we are able to do without embolization only when internal maxillary is the sole vessel. Because you can go do a Denker's, go to the pterygopalatine fossa, first control the vessel, devascularize the tumor and then remove the tumor. It is so easy. You can devascularize and remove it and allow it the endoscopic removal. But if you are not able to control the vessel first and trying to remove the tumor, it will never allow. It will bleed like anything. It will be a nightmare.
So Dr. Gurav from Kolhapur is asking his role of gel foam embolization. Anything gel foam embolization?
Yes, this is out of context here, but once you have asked, embolization is done in various ways. I tell you. Embolization is done in various ways, and there are particulate, non-particulate embolization. We have a huge discussion. We got a couple of patients embolized earlier as well. But I tell you in the present context, gel foam, particulate, PVC, all those are substandard embolization. It is not the main vessel which is plugged, which is going to, prevent the bleeding. Even if you block the internal maxillary artery completely with a PVC or gel foam, it is not embolization at a capillary level, and it is still going to give bleeding. It is not end artery. So once it comes to embolization, if you ask me, the gold standard is onyx. Onyx is a fluid material which embolizes to the microcapillary level. We have done 2 cases. The cost is a limiting factor. For this tumor, which I shown you, this tumor, I would need at least 10 or 12 onyx, each costing $1,000. So 12 onyx means $12,000. But then it will completely block the vascularity and you can remove the entire tumor with a microdebrider without any bleeding. That's it.
Okay.
Completely taken care of. So that is the value of Onyx, but the cost is a limiting factor. That is not practical in our country. Okay?
Okay, sir.
Any other question?
So Dr. John Shadow from Australia, he just got a case which he wants to tell you that a colleague had a case where the patient was a female with JNA, assuming that there was a genetic abnormality in the X chrome hormonal testosterone. They sent the patient for testing to find out if the patient was genetically male, hermaphrodite, etc. However, test came back normal female with normal hormone levels, but histology confirmed JNA. Have you
See,
had any experience with this? Is there a so
let
is
me,
there
there are so many such examples to confuse. Let me tell you, JNA is not a histological diagnosis. JNA is a single endothelial lined vessels histologically in the fibrous stroma, which is labeled as JNA in the background of the clinical history of a young male patient. Okay? It is not a histological diagnosis. Many of the vascular lesions have the same appearance with the vessels in the fibrous stroma. If the pathologist is blinded with the clinical details, they can report it as a JNA. Simple. So you don't get too confused. There are hundreds of such reports and people get excited. I got a JNA in a female, trying to publish it, but try to understand it is not a histological diagnosis. JNA is a clinical diagnosis, not a histological one.
okay, sir.
Okay. Now,
Yes, sir.
now, once we are talking about the carotid, this is important because once you deal with angiofibroma, you expect something more from radiology to protect the patient. So the carotid is the most important thing, and one must be, I take this opportunity for everyone, next 2 minutes, to tell you the course of carotid. Skull base surgeon or skull base anywhere, it is always carotid which you need to be careful about. So this is the course of carotid it's a serpentine course. This is cervical, this is vertical petrous, horizontal petrous, foramen lacerum. Then this is cavernous ascending, posterior band, horizontal cavernous, anterior band, and then subarachnoid course. Sphenoid and subarachnoid. This is the course of carotid. Now, for the junior colleagues to understand, let me show you this easiest way to understand this video. It's a graphic. This is the carotid ascending into the carotid foramen here. See, this is the temporal bone where the carotid ascends into the carotid foramen. See this? Here it ascends for a centimeter vertically, that is vertical petrous, and this is horizontal. What this is horizontal petrous carotid which runs in the length of the petrous bone here. Here it runs the horizontal petrous. And there it comes at the foramen lacerum to ascend up and become cavernous. Now here, let me stop it here. What is this picture? Here is the level of the foramen lacerum. This is the top view of the skull base where the brain is removed and the dura is intact. The view from above.
Yeah.
So the horizontal petrous carotid was running like it toward the foramen lacerum here. The previous picture. Okay. Yeah. Let me show you the previous picture here. Here. That was the foramen lacerum. So now we reach the foramen lacerum here. And now this is the dura. Now let me run it further. This is the middle cranial fossa. Now the dura being removed. Now see carefully. This dura being removed. Now what is seen? This is a trigeminal nerve in branches in the floor of the middle fossa. If you remove the trigeminal nerve, this is the carotid which is ascending. See, this is ascending cavernous portion of the carotid, which is crossed laterally by these nerves heading towards the orbital apex, third, fourth, and sixth nerve.
Yeah.
And this is the carotid. This is the petrolingual ligament, below which is foramen lacerum, and above which is the cavernous portion. Okay?
Yes.
Now, as this goes in the cavernous sinus, see now the nerves removed. Now this is the vertical cavernous carotid, posterior band, horizontal, and here turns to come as an anterior band. This is the entire cavernous portion of the carotid. Just to understand in the simplest way how the carotid has such a complex form. This is horizontal.
Yeah.
This is anterior band to come as a This is clinoidal portion where the clinoid process is. And see, this is the clinoid process, and the carotid runs medial to it. Here is the sphenoid sinus. This runs medial to the clinoid, and above this is the foramen for the optic nerve. Above the carotid remains the optic nerve. See, this carotid is here like this, and the optic nerve is there above. And see here, the first retrograde branch here arises. Anteriorly retrograde is the ophthalmic artery. This is how the course of the carotid artery is so complex. So in JNAs, in many of the skull-based tumors, we need to be careful about the carotid. And in this JNA, most of the time, it is the cavernous portion of the carotid we are concerned with. 99% of the time, even if the cavernous is involved, there is a good amount of periosteum separating from the carotid. It doesn't invade directly the vessel wall, and still you can pull. You can see a lot of videos of mine also on YouTube, the removal from the cavernous sinus. It doesn't invade the carotid itself, but you have to be very careful once you open the cavernous sinus. Not from the carotid, but the cranial nerve point of view. So this was just to give you an idea about the carotid artery. This, just in this context, to show you this patient from Iraq. This patient had this much of the tumor with complete 360-degree carotid engulfed. Can you see this? After taking care of all these parameters and preparing for the neurointervention and everything, and we could able to remove the tumor 100% with the post-op. So carotid is one factor which makes you do a substandard job, incomplete job because of the fear of complication. And to understand that, we need to understand the course of the carotid. We need to have a good setup with a neurointervention facility. We need to have a good workup pre-op about the cross flow and other studies, and then we can carry out this surgery. Now, in this context of the angiofibroma, another thing I would like to share here, which has a huge significance. Again, if we rely on the radiologist, we will never get that information. About understanding, I am again and again telling about the this thing, CT angiogram. Angiogram, even if you have, we have many a time we have come across. You get an angiogram, you have to rely on the radiologist report that these are the feeders. Believe me, that doesn't carry any value. If I tell you that you have a feeder from internal maxillary, okay, you have feeder from this. I tell you, once it comes to surgery, intraoperatively, it doesn't carry any value. Unless you know yourself how the artery is entering into the tumor. From which area the artery is entering into the tumor, can you tackle that vessel before removal of the tumor? Then only you go endoscopy. That information you can get once you know yourself how to read CT angiogram. Once you yourself will see the CT angiogram, that how the vessel is entering into the tumor, then you can only handle the tumor. Otherwise, will be a disaster. You open up the case and the bleeding starts, and you have no way to control the breathing. Let me tell you what it is. Let me show you the CT angiogram. See this. In next 2 minutes, in the simplest way, I'll tell you what ought to be seen on CT angiogram. Just 2 minutes.
So which is the best section suited in MRI to locate the internal maxillary artery? Maybe this also you can tell us later.
Pardon?
Which will be the best section where you can locate the internal maxillary artery in MRI?
MRI? On the coronal section.
Yeah.
And to locate the artery, I tell you, it is not the section which is important. It is the CT angiogram which is important. That's what I am coming to. Now, can you see the CT angiogram? Can you see the scan which I am running?
Yes, yes.
Now, let me tell you what I am trying to show you first. It's not difficult. Try to understand. Come on. What is going? Okay. Just a minute.
So these angiopharma should be done under with the help in the presence of neurosurgeon or no? You need to have
No. There's no role of neurosurgeon at all.
Just for you can say legal point of view or like.
No, not at all. Now see what I'm coming to. My point is, we have realized this difficulty. That's what I am sharing you. If you have the CT angiogram, earlier I used to get, and the radiologist said you have a vessel, this vessel, which is feeding the tumor. Let me show you exactly.
So while you're searching, you can also tell us that which is the best time to operate after embolization?
As earlier, within 24 to 48 hours.
Okay.
Okay, now I tell you something, what I wanted to show you. Let me go back. This is just 1 minute. See now, the aim of what I'm trying to show is to know the feeding vessels, okay? And how they enter into the tumor. If you don't know why I'm saying this, if suppose I give you the information like radiologist, you have an internal maxillary, which is the principal feeding vessel. Now, what you all want to know, how the internal maxillary is entering into the tumor, whether it is feasible to control that vessel or not intraoperatively. Now see, can you see on both sides the common carotid?
Yes, sir.
Can you see this?
Yes, sir.
And this is the internal jugular vein.
Yes.
Okay. Now see the common carotid dividing into two.
Yes, sir.
Internal and external. Is that clear?
Yes.
Now see, follow. This is external carotid. This one where my cursor is. Can you see my cursor?
Yes.
See the first branch coming out of external carotid. Can you see this?
Yes.
This is ascending pharyngeal. Now I forgot the carotid. Now I am tracking the ascending pharyngeal. Can you see where my cursor?
Yes.
You have to track this vessel whether it is going into the tumor or not. This was lingual. This is not ascending pharyngeal. Can you see that?
Yes.
You have to follow each and every branch of external carotid. That which one is external. Now this is second branch. This to me looks like facial. Can you see this?
Yes.
Where I am following with my cursor. See, this is facial. It is going over the mandible. See this?
Good.
See, this is a huge tumor. Okay. Now I will come with the next branch. See, this is external carotid.
Yes.
Now see the entire external carotid going behind. Can you see this?
Yes.
And at the angle of mandible, this will divide into two branches. See this? This dividing. This one is internal maxillary and this one is superficial temporal.
Yes.
Can you see?
Yes.
Now see the internal, follow the internal maxillary. See such a huge internal maxillary entering into the tumor. Can you see?
Yes.
Now, if I am given this case to operate endoscopically, what would be my first aim? To tackle this vessel first.
Like it.
Now to tackle this first, I have to come across through the depth of the tumor far behind to tackle this vessel. I would never do this case endoscopically because I cannot control this vessel unless I go through the tumor. So even if your radiologist is saving the principal blood supply internal maxillary, is as good as useless unless you yourself see how the vessel is entering into the tumor. That is the significance of knowing yourself to read the CT angiogram. Got my point?
Yes.
Now see the other vessel. See this is the internal maxillary. Now the other vessel. See this superficial temporal. See I am following with my cursor. See this? See this superficial temporal is going into the tumor. Can you see this?
Yes.
So if your angiofibroma is taking blood supply from superficial temporal, forget about endoscopic surgery. One can never control the superficial temporal endoscopically on this planet. So angiogram is deciding in large tumors whether you can tackle endoscopically or not. Such tumors, if you really want to tackle endoscopic, you have to get a proper embolization done. Embolization is not all that easy. It's not risk-free. It depends upon the competence of the intervention radiologist, the experience of the intervention radiologist, the cost, added cost, and the risk of complications. So you have to have in your team a good, reliable intervention radiologist. So it requires a teamwork. And such each and every branch of the the carotid, the internal and external, need to be thoroughly looked into. See this, internal. You need vertebral artery. Sometimes I've got a case with a feeder from vertebral artery. And you cannot ignore that. You need to see yourself that what vessels are supplying, what are the feeding vessels, what other vessels going to the tumor, the venous drainage, everything you can see on the CT angiogram. And that the bottom line is you need to see yourself. The radiologist report, like CT PNS, radiologist will report pen sinusitis, no value. Radiologist said this vessel supplying no value. To optimize your results, you need to see yourself how to read the CT angiogram. That is the bottom line, which I wanted to convey.
Dr. Yosef Saleh, he wants to know what is the carotid occlusion test? What is its value on this thing?
That's important. Carotid occlusion test is to predict, to know the information about the cross flow. There are a number of tests, n number of tests outlined in the literature to predict the cross flow from opposite side in case the vessel is blocked, in case the vessel is closed, embolized, coiled, whatever, main internal carotid. So what you do, that balloon occlusion test is on the same side, you occlude the carotid with a balloon, awake patient. And if the cross flow from opposite side is good, wait for half an hour, 45 minutes and monitor the neurological condition of the patient. If it is stable, that means the good cross flow is coming. That's a basic test. It has a sensitivity of 80%. Now, what we do in our practice, if you have asked, to improvise the sensitivity of this test, what we do? We do this test in the hypotensive conditions.
Okay.
In a controlled hypotension, if you are doing balloon occlusion test and still there is a cross flow from opposite side, that means that patient will maintain the flow from opposite side. Because if you don't do in the hypotensive condition, in the post-op, the patient passes the test good, and the post-op patient goes in hypotension, he will have a stroke. So do in the hypotensive condition to improve the sensitivity of the test.
Okay, sir.
To improve further sensitivity, you put a balloon on the opposite side also and pass a catheter through it to see the backflow of the back pressure after occluding the same side carotid. If the back pressure is more than 2/3 of the systolic, then you rest assured that nothing will happen. So that's a different subject. I cannot go in detail here, but that test is important once you deal with a tumor which is involving the carotid artery. That's an important thing.
What are your post-op radiological protocols after doing surgery, angiofibroma, when you go for CT or when you go for MRI to check whether you have done a perfect dissection or not?
Yes. See, that's a good question. To me, it depends upon your surgical resection. Your experience, if you have removed and you know that you have completely removed, with no question of leaving any tumor behind, you can wait. On a slightest suspicion, you can go in the immediate post-op period with a good contrast fat suppressed MRI.
Okay.
Fat suppressed will tell you the marrow part as well. And in that situation, if there is, you can go back and remove that. It is your suspicion which makes the difference. And that suspicion comes from the experience as well. Sometimes if you are overconfident and you say that you have removed and left the tumor behind, that's a disaster. So you have to make your own protocol.
Okay.
Any more questions?
Does Denkers, doing Denkers for Jain excision in adolescent male going to affect the growth of facial skeleton later? Gopi Shankar from Mumbai is asking this question.
Not really. It has been studied. Not really.
Okay.
When Dr. Sripati Naidu, not talking about you, means what is the limit of doing endoscopic GNA excision? Means when you recommend going for the mid-facial degloving or maxillary swing surgery, like.
Who asked this question? Sripati Naidu.
Yeah.
Sripati Naidu is here with me.
He is asking.
Oh, there's another Sripati Naidu. Yes, you see the Sripati Naidu. Always.
That's why I'm asking. But
always laughing. Always.
But it's a good question put by him.
Okay. So the role of open approaches in this endoscopic era. First of all, before you take up the endoscopic treatment in your hand, you must be well versed with the open approaches. That's first I would recommend. And 3 approaches I will recommend everyone to be well versed with before taking up endoscopical. 3 versatile approaches. Number 1, lateral anatomy.
Yeah.
Number 2, maxillary swing.
Yes, must.
Number 3, Lefort 1 approach. These 3 approaches gives you opportunity to remove each and every extension of the tumor except intracranial. In case intracranial, you have to add on with a subtemporal approach together. Now, in this era, if you ask me when to go open, for me, open approach is required once the tumor derives the blood supply from the internal carotid system more, which cannot be embolized, which has a high propensity of bleeding in a revision situation, and once the tumor derives the blood supply from the intracranial feeders. Many a times you have seen patients getting blood supply from the middle cerebral artery. No way you can think of taking those cases endoscopic. You have to go by open approach. But in spite of doing endoscopic, you must be well versed with 3 approaches. Maxillary swing is a versatile approach. So fast, 15 minutes time you reach the skull base and remove any extension.
I think one of the best technique for.
Though it has its own morbidity, but one must be well versed with it.
Sir, there's a question from Kathmandu. Dr. Bigyan is asking, how do you differentiate between Jain and other vascular tumors like rhabdomyosarcoma in an adolescent male presenting with epistaxis? Are there any characteristic MRI feature between these?
This is Dr. Bigyan from Nepal.
Yeah.
Okay. So, I have already mentioned this. On the JNA, diagnosis is almost always clinical, and that diagnosis is reinforced by certain characteristic radiological findings. I have already mentioned the JNA has a propensity to invade certain areas, which gives us diagnosis. Propensity to invade infratemporal fossa, propensity to invade pterygoid process, middle cranial fossa, cavernous sinus, which is classical of JNA. And it's almost always diagnosed like this. Rhabdomyosarcoma is a different entity, is a different presentation and different extension pattern as compared to the JNA. JNA is characteristic extension pattern by means of which it is diagnosed.
Sir, how will you prefer controlling the maxillary in JNA by suture or cautery?
Controlling what?
The controlling the maxillary internal maxillary artery in JNA.
See,
what do you use?
Whatever you control is different. The thing which matters is the exposure. Endoscopically, if you have good exposure, I have done all these things. I have bipolarized the vessel several times at multiple places with no clip. I've used the unipolar even in many of the cases and put a gel Surgicel over it. And nowadays, I am more and more putting a clip to be more secure, you can say. By any means you can do. It's up to you. But clip is giving a sense of security more than anything.
Yes,
sir. There's a question from Shripati. Okay. Shripati is
okay.
Shripati is here. There are so many Shripati. It is always smiling.
Actually, it's the best way to ask the questions. And
ever smiling Shripati Naidu.
Yeah, he's very good.
Yes, sir.
Ultimate. Yes, sir, please.
Pardon?
Now, next is yes, sir, please.
Yeah. So just to tell you, sir, just to boost you, there are 5,700 ENTs watching you right now.
Oh,
all over the world.
So crazy people. I never knew people are so crazy.
One more announcement I think I would like to do.
People are so crazy, spoiling their Sunday evening.
Yeah, Sunday evening. One more announcement is that on Thursday, 5:30, I think, Dr. Satish, from 5:30 on Thursday, we will start live surgery. And we will give one case, basic case, followed by a talk on the complication of sinus surgery. It's okay? 5:30 Thursday.
Yeah, we'll go ahead with a live surgery.
Yeah, live surgery.
We'll demonstrate one case of pen sinusitis, polyposis, and then follow with the topic of complication to complete this subject. Last time we discussed about the concept, understanding at the molecular level, medical management, decision making. Today the radiology. Next will be surgical intricacies, and then next will be complication. Then this subject will be over. Just to finish off. Later on, we'll do a next series of cadaveric dissection later on. So now the next topic is, do we go ahead?
Yeah.
Yes.
Any more questions?
Sir, this Iseric software, is it good for image viewing on the laptop? Because
Yes, yeah, that is, Osirix is very good for Mac,
okay.
MacBook.
Yes. Okay. Okay, sir, we can go ahead.
Okay. So the next important issue in our practice is CSF leak. And again, an appropriate radiology is game changing. That's why I kept this topic. Today, it's all about radiology, how radiology can be game changing. We have seen so far. In CSF leak also, and again, the same word, MRI. Now, CSF leak is not always so straightforward that patient coming to you with a unilateral nasal discharge and you get a CT scan like this and get a defect and you seal and come out and the patient gets all right. There's a history of trauma, CSF leak, you get the site of defect on CT scan and you repair and you come out. This is not always stands true. Many a time you have a diagnosis of history of CSF leak, but you are not able to identify the site of leakage. Now, this presentation, try to understand, this is very, very important in our practice. And I will take you through certain investigations by means of which you can optimize your outcome. On the right side is the MRI, T2 weighted MRI showing the same intensity of the CSF coming into the nose, confirming the CSF leak. With CT scan, a defect into that place, sometimes there could be an old defect with fibrosis, may not be the site of leak. But with MRI showing the CSF flowing out at the same site, confirm the diagnosis. Isn't that? Okay?
Yeah.
So now, what are the different investigation and what is the value out of them? And when to use what? The pros and cons. So first is like you saw the HRCT scan, which I showed you earlier, this one.
Yes.
In a patient with a history of trauma, on the same side you get a defect, that's it. You don't need any other investigation in those subset of patients. Okay? And other investigation are not for those patients. Others are in the situation when there is no history of trauma leading to the CSF leak, or in difficult CSF leaks, doubtful CSF leaks. So what are the other investigations? CT cysternography, a very popular one at one time. For me, it is obsolete. For last 7 years, I have not got done a single CT cystonogram. To me, this is obsolete, contraindicated. It is disaster sometimes. I'll tell you the reasons. Useless. The next one is MR cysternography. Here you can see the MR cysternograph. What is MR cysternography? It's non-invasive. It's a simple, heavily T2 weighted MRI, wherein the CSF fluid is made prominent, bright, against the dark background of tissues. So see this, CSF flowing in continuity into the nose. Can you see that?
Yes.
This is MR cystonogram, non-invasive. Unlike CT cystonogram, where you have to inject the dye in the intrathecal space, MR cystonogram doesn't need any dye. So it has a value over CT cystonogram. There is no unnecessarily need of injecting any dye. Okay? For both these investigations, whether CT cystonogram where you inject a dye in the intrathecal space, or MR cystonogram where you don't inject and you find the CSF space in the nose, for both the investigations, they will pick up the leak only when at the time of scanning there is active leak. What's my point?
Yeah.
If you have a patient of spontaneous CSF leak, at the time of scanning, if there is no active leak, whether you get a CT cystonogram or MR cystonogram, it will turn out to be negative. and again you are in a fix. Next investigation is gadolinium enhanced MR cystoscopy. This is our gold standard investigation now for the indications which I am going to tell you. Okay. So now, first of all, HRCT scan where you get a bony defect. CT cystogram. Why I said this is obsolete. Some people consider it like a gold standard investigation, and it looks so fascinating as well. Looks so fascinating for the reason you inject the dye in the intrathecal space, and the dye traveling through the subarachnoid space coming into the nose like this in this picture. In this picture, that confirms the CSF leak. There is no harm in this investigation. It looks so fascinating. What is the problem?
Yes.
The problem number one is you need to inject something in the intrathecal space, and that to an iodinated contrast. Iodinated contrast is not free of complications. Many of the CT cystogram patients develop severe complications, even seizures. You need to be admitted in the ICU many a time, we have seen. Secondly, the iodinated contrast stays in the intrathecal space for limited time. And it doesn't flow so freely in the basal systems.
Okay.
You literally have to put the patient in the prone lower down condition for the dye to flow in the basal areas. Such awkward position you need to put the patient into, and in few hours, 2-3 hours, the dye disappears. Now, on that period, if there is an active leak, only then this will pick up. Okay? That's why for these reasons, number one reason, it will pick up only active leak. It will require intrathecal administration. It will require iodinated contrast. It is an investigation with a radiation hazard, CT scan. The dye is not free of reactions. It doesn't stay in the intrathecal space for longer time, and it doesn't flow freely in the basal system. Because of this disadvantage, this investigation has gone disrepute. With the availability of other good investigation. What is other good investigation? For the patient who has active leak, which can be picked up by a CT cystogram, can be easily picked up by a MR cystogram without the need of injecting the dye. That's it. Why to get CT cystogram done? If CT cystogram cannot pick up any patient because of non-active leak, MR cystogram will also not pick up. And those are the most difficult situation and what to do with that. I give you an example. Many a time, patient come to us, I have an intermittent CSF leak. Yesterday I had, 3 days before I had, today I have no leak, like that. Many times your operated patients, post-op, you are in a fix. You have done some skull-based surgery. You are in doubt whether there is a leak or not. You are not very 100% sure that there is no leak. Sometimes you are referred a patient, we have many a time referred by neurosurgeon many, that I have a doubt is a CSF leak. I am not able to pick up. I have got CT and MRI done several times, not able to pick up, and he has an intermittent leak. The moment you get the scan done, MR or CT cystogram, at that point of time there was no active leak and this investigation will never pick up. What's my point?
Yes,
So
yes.
what to do for such difficult patients? For such difficult patients, our gold standard investigation is gadolinium enhanced MR cystogram. Why I am saying so? This is the investigation for last 5 years. Where number of patients were able to rule out whether there is a CSF leak or not. Finally, there is no investigation about it. Particularly in difficult to detect CSF leaks, in intermittent CSF leaks, this is the investigation of choice. I'll tell you the reason why. Why this is gold standard. Why it is so safe. Why it is so sensitive. Number one, this requires intrathecal administration of a dye, which is known as gadolinium. Unlike CT cystogram, which requires iodinated contrast, this requires gadolinium, which is pretty safe in hardly any reactions. Number one. Number two, unlike iodinated contrast, which doesn't diffuse so freely into basal system, gadolinium freely dissolves in the CSF space. Freely. Number three, Unlike iodinated contrast, which washes out in 2-3 hours in CT cystogram, gadolinium stays in the intrathecal space for more than 24 hours. That is the beauty. That is the beauty. Unlike CT cystogram, which requires a radiation hazard investigation, CT scan, MRI is radiation free. What's my point? Now, in intermittent and difficult to find CSF leak when there is no active leak, why this investigation is investigation of choice and how to do it? We inject the gadolinium and counsel our patient to stay in the MRI space, MRI area in the clinic for at least 24 hours and repeatedly MRI done every 2-3 hours, because this is radiation free. You can repeat MRI as many number of times as you want. And number two, the gadolinium stays in the intrathecal space for more than 24 hours. Even in the intermittent leaks, you may not get on the first time, second time, third time. We got a patient after the 8th time scan. We got the gadolinium flowing into the nose because that was intermittent leak and it was picked up during that time on the H scale. You cannot repeat CT cystogram 8 times. It is radiation hazard. Number two, the iodinated contrast doesn't stay for such longer period. Gadolinium stays for 24 hours. MRI is radiation free. You can repeat again and again in such intermittent and difficult leaks to get a final diagnosis whether there is leak or not. And for me, any patient who passes repeated MR cystogram after gadolinium, after repeated scan for 24 hours and passes negative, you can label it as a negative for CSF leak. There is no investigation above it. That's why it is considered the gold standard.
Okay.
But my point,
Yes,
that
sir.
is the investigation of choice. Any doubts, any questions?
Actually, we are doing all the radiology. Now, second goes for the clinical examination or the fluid examination like beta-2 transferrin. And so those are also tests we can find out. Suppose we can give the vial to the patient and he can collect at home and then we can ask for this practical.
I am giving you information, beta-2 transferrin positive. The issue is where the leak is coming from.
Yeah, just to find out the site of the leak, but for the whether leak is there or not, that one more things are there. Yeah, radiology just to find out the site.
I tell you, beta-2 transferrin is not a simple test.
Yeah.
You need to have an adequate sample. It
Not available
requires
everywhere.
time. It requires time and a huge
Not
cost
available
involved.
everywhere. Not available everywhere. That is one.
And a huge cost involved. That is so difficult. It's not so practical. And that too will not tell you where the leak is coming from.
Yeah, site.
Satish was.
Yes, yes.
I mean, that's a very interesting concept. I've never heard this thing earlier, right?
I'll send you publication.
My simple issue is, I saw literature to tha is pe, but my point is, I think what I could understand is you are trying to say कि we give intrathecal gadolinium and we repeat MR maybe 10 times if required.
Yes. Up to 24 hours.
In the first
until it stays in the in the subarachnoid space.
Yeah. So that would help us कि जब भी intermittently, whenever this patient is having a leak, that would be shown in this MR.
We'll be able to pick up. That's it.
Exactly. Now my point is, okay, I want you to counter in this in the fact that, if I were to say that this particular patient is not given intrathecal gadolinium, but I do his MR cystoscopy any number of times, right? It would still give me the same result. So why give gadolinium?
Yeah, I tell you, MR cystoscopy. See, let me show you this MR cystoscopy.
Yeah.
This MR cystoscopy is done with a 2 mm, 3 mm section. Any time a small leak is missed because there is no contrast. There is no contrast. With this, even a tiny leak, tiny contrast coming out will be picked up. Even you may not see the continuity. You may not see the continuity. Even if you find a tiny contrast in the nasal cavity anywhere, that is considered CSF. MR cystoscopy will pick up only in continuity, nothing else. That's the value of gadolinium and without gadolinium. That's the beauty of this investigation. That's why it is considered gold standard.
Okay, and this is pretty safe then, right?
And it's absolutely safe. Manish, I have got more than 70 patients done. Absolutely safe. Absolutely safe. The thing is to counsel the patient to stay in the MRI area for 24 hours,
Yeah,
repeatedly getting scanned. The cost is involved because the MRI people will charge every time.
yeah, yeah.
That is the only issue.
Achha, you will still, okay, let's, just for the purpose of discussion, this patient will still require a NCCT PNS, right? You will not operate without it, or will you?
Yes, CT scan is a necessary thing as well to see the bony anatomy
Yeah.
and to see the bony defect if any. Many a time those bony defects are overlooked and not picked up in the small defects. But still, CT PNS is required once you repair a leak.
Okay, so if I were to say that if I have a patient of CSF rhinorrhea, I get a CT scan done and I get a MR cystoscopy done. अगर पहले उसमें मुझे दिख जाए leak, then I do not give gadolinium.
No, not required. Not required.
Then it's good enough, right? So not every patient would need it.
No. This is only for intermittent, difficult to detect, suspicious leaks which are not able to picked up, easily. This is only reserved for those.
Yeah.
Okay.
Yes, Dr. Kusum Patidar is reminding you one case where all the tests was done, but you could not find any leak, and the site of the leak still CSF was there. You kept under observation, but patient is doing very fine. And how many cases you have?
Such are so difficult patients, believe me. And I am in touch with a lot of neurosurgeons every day. They are done some surgery and they are quite sure this is a CSF leak. I am quite sure. And I have a fear that it is meningitis. And such studies I have got done of several patients. Many of were able to pick up. Many a time on the strong clinical suspicion, we repeated this study twice. Believe me, if somebody passes this 24 hours, you can label it as no leak. As simple as it. Because in the present context, there is no investigation about this. Unless you find the patient next time with an active leak that you can pick up. There is no other way.
अच्छा बस एक चीज और ये FDA approved है कि अपन off label use करें?
Yes, FDA approved. Gadolinium can be used.
Intrathecal gadolinium, right?
Yes, intrathecal fluorosin is not approved in India. Gadolinium is approved.
Okay.
Iodinated contrast is approved. My proposition here to the audience is forget about CT cystonogram. That's it. No value. It is obsolete, means obsolete. No question over it. Now,
I think one of the
coming on to the...
Sorry, I think one of the advantages will also be that, getting this MR with gadolinium may actually identify any small lesions in the brain itself.
Yes, it can find out. For any CSF leak, I agree with you. Except for the traumatic ones.
Yeah, except traumatic.
That's what I'm coming to in the next part.
Yeah.
All CSF leaks, we should evaluate with MRI.
Yeah.
Not only to rule out intracranial lesions, but to rule out intracranial pressure. That is more important.
Yeah.
Because except the traumatic ones, the rest spontaneous majority have the intracranial pressure as a primary pathology. Leak is a manifestation.
Okay.
So this was gadolinium. Now, pardon?
Now, what is the smallest size of the defect or the maximum size of the defect you will recommend to go by the endoscopic approach or by surgical approach?
Smallest size of the defect?
Yeah.
Any defect you have to...
Or maximum size, you can do endoscopic?
Any defect now you can handle endoscopy because now with the availability of so many vascularized flaps, you can tackle any. We have repaired defects of centimeters. Rather, not repairing, we are creating defects of centimeters now. That era is changed. In 90s, when the endoscopic CSF rhinorrhea surgery was introduced, repairing a 2 millimeter defect used to be considered as a supramajor surgery. Now in endoscopic skull-based surgery, every day we are creating defects in centimeters.
Yeah.
By transcribiform, transclavial, so many approaches. And then we repair with a vascularized flap. These guys, the Haddad and Besageste has revolutionized the endoscopic skull-based surgery by introducing Haddad flap. And now More than that, now more than 15 slabs are available for us, vascularized slab to repair. Whatever size defect, if you have a 5 centimeter defect, I'll still go endoscopy. I have a lot of options to repair. Now, Monish, what the question you asked is this slide.
Yeah.
This patient was operated somewhere. See, this anterior canal fossa was repaired. Some tumor was removed, completely removed. Anterior canal fossa was repaired. This patient had a doubt to the surgeon doubt of CSF leak. He got 4 times the CT scan MRI and couldn't pick up. This patient, after 1 month, again the patient became psycho after that I have a CSF leak. I have been explained that this leak continues. I may develop brain infection. Because the surgeon himself told him earlier when he was trying to pick up. So he came and see the repair. With this repair, you cannot pick up by CT scan anything. This is all fibrosis and all tissue what he used for repair. MRI didn't show anything. And this is what the gadolinium. See this? There was a defect and it was picked up on gadolinium, enhanced gadolinium, and we repaired it and wonderfully doing. So this investigation, we need to understand when to use. In difficult situations, this is the only investigation of choice, nothing else. Okay? I hope it is clear.
Yeah.
Any more questions?
So do you feel getting an MRI in prone position or change in position to promote leak is helpful?
In gadolinium enhanced intrathecal MRI, unlike CT cystonogram, you don't have to push the patient in the prone position high up, lower down, because the gadolinium diffuses freely in the subarachnoid space. Unlike iodinated contrast. Have you seen anybody doing CT cystonogram sometime in life? You will never advise if you see somebody doing. They literally inject the intrathecal, lie down the patient prone, and 2 people raise the legs up and head down for 1 hour, 50 minutes, 1.5 hours until the iodinated contrast come in the basal system. That is so cumbersome. It is so pathetic you can think of. So this gadolinium, you don't need to do all that because it diffuses freely in the intrathecal space. That is the main advantage, you can say. So now, another thing which is game changing, I tell you, like Monish said, MRI is required. Yes, except traumatic. When you have a history of trauma, same side leak, get CT scan, defect, repair. That's it. You don't need anything else. Except that situation, any other CSF leak, spontaneous, requires to be assessed by MRI for various reasons. Number 1, like Monish said, you need to rule out any intracranial pathology, tumor, anything. And second most important is the high pressure. Majority of these times, these patients with a spontaneous leak, the spontaneous leak is a manifestation of ongoing high pressure in the brain. You can imagine, brain is a closed cavity, closed bony cavity full of fluid into which the brain floats. Now, if that pressure of the fluid is constantly elevated, what is going to happen? It will give us some or other time at the weakest point. And that is what the spontaneous CSF leak is. Now, what will happen? If we ignore that part and try to seal the leak is serving as a pressure release valve. And now if you try to repair it without looking at the pressure, what will happen? It can again lead to pressure buildup. So the primary pathology many a times is the high pressure, not the leak. And such patient we need to counsel differently. Differently means, obviously, the primary thing is to seal the leak to prevent meningitis. That's the priority. But at the same time, you have to tell them we have to manage the pressure afterwards. That may require medical management. Most of the time, medical management handles.
Yes.
If doesn't control, which may require surgical management, may require more workup or endovascular management. I'll tell what exactly that is. So the pressure management is equally important. That is a part of counseling. Otherwise, what will happen? You see the patient was repaired spontaneous leak meningocele, absolutely sealed, and patient came with a vision problem, papillary edema. That led to pressure buildup again because the pressure management was ignored. I hope you got the point, how important it is. So, first of all, on MRI, how to get an idea that patient has a high pressure sign. See this list of signs you can read out. All are these signs which can give you suspicion of the patient has a ongoing high intracranial pressure. Okay? Now, this is the simplest of one. What is this? Empty sella. What is empty sella? This is sella. Where is the pituitary? It is pushed behind here. The entire sella is replaced by the pouch of arachnoid, pushing the pituitary in one corner, and the majority of the sella is full of CSF space. That is because of the high intracranial space. This is empty sella syndrome. Then, you know, the subarachnoid space goes along the optic nerve, along the sheath. All the three layers of meninges goes along the optic nerve until the sclera. See this? If the pressure is high, the sheath covering the optic nerve will be distended. See the sheath, how distended it is. That's an indirect sign, and majority of such patients present with vision problems also. See this, optic nerve tortuous, and see the globe. Because of the high pressure, CSF pressure from behind, it has flattened. Can you see this?
Yeah.
Flattening of the globe, and the optic nerve is protruding inside the globe because of so much of high pressure. See the distended CSF space around the nerve. These are classical signs of ongoing high pressure. That's the utility of MRI. These are the MRIs of the patients who had CSF leak, spontaneous leaks. So ongoing high pressure, if you ignore, that is not going to work. If you seal the leak, the patient will come back with other problems. So all these are signs. See this optic nerve in the sagittal plane. See this vertical buckling because the nerve is distended because of the distended sheath around. See this space from the optic nerve head, scleral head, length of the nerve is 1 centimeter more than the length of the distance. What's my point? The nerve is loosely placed in the fatty tissue in the orbital space. Okay? Once it is distended with the sheath is distended with the CSF, nerve becomes tortuous. And that is the classical sign you can pick up on MRI as a sign of high pressure. See the Michel's cave, so distended. Michel's cave contains CSF.
Yes.
So what I'm showing is all signs of high pressure. Now, what is the importance? And now I have got to the MRI, the patient, particular patient who has a CSF leak, spontaneous, has a high intracranial pressure. Okay? Now what to do? First, we will repair the leak, no doubt about it. Our strategy is to repair the leak. For next 24 hours, we don't do anything. We allow the CSF to be completely replenished in 24 hours. We have a CSF volume of 150 ml, and it circulates 3 times a day at least. So in 24 hours, the pressure, if we check after 24 hours, will give us a normal value, existing pressure value, normal, once it is completely replenished. So in those situations, we do a check lumbar puncture after 24 hours and take the pressure. If the pressure is within 20, nothing is required to be done. 20 to 30, the first line management is medical management.
Yes.
This is borderline. If about 25, you can consider a planned patient in the future for shunting, diversion, ventriculoperitoneal or thigoperitoneal shunt to divert the CSF pressure. But if it is about 30 or 35, that is alarming. That cannot be managed simply by shunting. If the pressure is about 30 or 35, then the next investigation to be done is this. What is this? MR venogram. This year, we got 3 patients stented. Patient had a high CSF pressure, presented with CSF leak. Very high pressure on lumbar puncture, 35. We got the MR venogram and see the transverse sinus thrombosis. How the CSF is circulating? Once it is produced in the choroid plexus, it flows to the ventricles and absorbed in the venous sinuses. Okay? If the venous sinus is thrombosed, where the CSF will absorb, there is persistent elevated pressure. So MR venogram showing this picture of transverse sinus thrombosis, stenosis, unless and until you reverse this pathology, whatever you are doing is useless. Even if you put a divergent shunt, may not work. Shunts have their own complications also. So for them, the primary pathology is now diagnosed, and for this the answer is endovascular stenting. That's it. You reverse the pathology and patient is cured. That's how these patients have to be managed. A patient coming to you with CSF leak, it's not all that simple that you close the leak like repairing a puncture and you get away. You have to understand the physiology behind that. You have to find out the cause behind that and repair that cause to get a final answer. I hope it is clear.
Yeah,
Yes,
yeah.
sir.
See some examples of venous sinus stenosis. Those have to be repaired. Persistently elevated pressure, you can see how the caliarium becomes thin because of the CSF pulsations. It's normal and the CSF leak. That's how it erodes the CSF, the skull base. Any question here?
Any
So
miss?
now-
So you ask.
So what are the measure to reduce idiopathic raised ICT post repair?
Pardon?
Post repair, if there is raised ICT, what are the measures to reduce?
That's what I mentioned. First of all, we confirm after 24 hours of repair, when the CSF, the flow dynamics is established. If it is high, the first line is the medical management, diamox and diuretics. If it is too high, then you can think of putting a shunt. And if it is too high, then get MR venogram and rule out the venous sinus thrombosis. If it is, then you have to stand aside. Otherwise, shunting.
Any radiological difference may suppose a meningoencephalocele or plain Caesar granuloria. Any radiological difference in protocol?
See this. See the next slide.
Okay.
See the next slide.
Yeah,
This is the CT scan of the patient.
Yeah, yeah.
As a through and through defect and something coming down.
Yeah.
On T2-weighted MRIs, the bag full of water, CSF. Can you see this?
Yes.
Bag
Yeah.
full of CSF. This is meningocele. Another entity is meningoencephalocele. See the brain tissue hanging down with
Yeah,
CSF. So these are two different entities. This is meningocele. Can you see?
Yes.
Yeah, very
And
clear.
this is meningoencephalocele. But on CT scan, you will find this opacity. That's it. CT cannot differentiate further into the soft tissue. Whether it is meningocele or meningoencephalocele, you need to have MRI. See this? That's the beauty of MRI, to give you this information.
Yes.
Good, good, good.
Any question here until here?
No, it's okay.
Oh.
Any Paramita?
People are asking about the posterior table frontal leak. Can be done. Can you talk about the posterior table frontal leak?
Yes. So, posterior table frontal leaks are difficult leaks, considered difficult earlier, but nowadays, majority of such leaks can be handled endoscopically. In our series, we now almost always handle endoscopically. Why I'm not saying 100% is the reason. It depends upon the anatomy of the frontal sinus as well. See, if you have a small sinus, what you can do, you can remove endoscopically the entire mucosa and obliterate the sinus from endoscopically. Too big and laterally placed, you have to do a draft and go laterally. If it is far laterally, you can come from the contralateral side transseptal and go laterally. You can do orbital transposition endoscopy and go laterally. So majority you can repair endoscopic, except in difficult situations, sometimes revisions and all scarring, you can think of going by open approach.
Okay.
Majority you can handle endoscopically.
Okay. And so what is the role of topical fluorescein in OPD and intraoperative in CSF leak?
Amazing. Amazing. Topical is amazing. The reason is intrathecal is banned in India. But topical has a place where it is amazing. You are operating on a leak, on a patient, sinus surgery or anything, and develop a doubt of CSF leak, that you may have given a CSF leak. You're not very sure if you have given a tiny leak or not. What you can do, take that topical fluorescein there in a cotton ball and run along the skull base. Wherever it comes in contact with the CSF, it will turn yellow-green. You can immediately, even a tiny leak will be picked up. Secondly, you can utilize it at the end of planned CSF leak repair. You have repaired a CSF leak and you want to ensure a complete seal. Repair, wash with the saline, and then take the fluorescein soft cotton ball and run along the skull base. Wherever the CSF, it will turn. It will show you even a micro leak. So it has an amazing value.
Okay. We can continue with the imagings of malignant tumors.
Okay, this is one step beyond. This is one step beyond because this is important in the decision making. And like we use it very often as we do a lot of skull-based malignant tumors. The the decision making means whether the dura is involved to be resected or not, whether the orbit is involved warranting orbital exentration, whether the patient is resectable or not, is the perineural involvement. I'll give you an example, simple example. See how often we overlook. Patient had a buccal mucosa malignancy, was operated in a cancer hospital. Good commando resection done, wide excision done, neck dissection done, that's it. After 3 months, patient coming with a headache. Went to the oncosurgeon, he said, nothing. You have operated for the cancer, everything has gone good. Looks like psycho, and given some tranquilizers. Patient was bent upon the pain. So he came to us to get a contrast MRI done. You'll be amazed. That area supplied by the mandibular branch of the inferior alveolar branch of the mandibular nerve had a perineural invasion from that inferior alveolar nerve down the mandibular nerve to the cavernous sinus, giving headache. Had that patient, what I believe, we have seen many a time, had such patient before operating been assessed by MRI, you could have picked up perineural spread. So if a localized disease having perineural spread going to the cavernous sinus, what is the fun in operating those patients? We can overlook certain things because perineural is not that squamous cell carcinoma cannot have perineural. Adenocystic has a high chance, but even the squamous has perineural in certain segment of it. It can happen anywhere, and there is no policy like all cancer to be evaluated by MRI. So there are so many lacunas we are missing, and further with the help of imaging, we can improve our results and avoid such situation. So these are the situations you can take the help in the cancer patients, imaging of malignant tumors, by getting this information to improvise the decision making. So, and this can happen with MRI only because MRI can give you soft tissue details, not CT scan. CT has just value we discussed in initial 20 minutes about the PNS, the bones, that's it. CT doesn't have any more role further in the management of any sinonasal diseases. Tumors, always MRI because of all these regions mentioned, which I have already enumerated. So, quickly now, I have been told that I have 15 minutes. Boss, is it?
Yeah, means 10. You told us 10 p.m. is I think limit.
See, you tell me how much time I will rush and finish it off.
No. Time is not easy, but I think we can finish this your lecture first. Then we will take the questions.
Sir, can you quickly tell us the duration of
my this presentation, the pace at which I am going, it will take another 3 hours. So tell me practically how much time you give me. I will just touch upon the important issues and come out.
We can have 20-25 minutes, no problem.
Okay, 25 minutes I will cover up the important issues. So
quickly, can you
quickly,
tell the duration of Dimox that you give?
pardon?
Many Dimox, duration of Dimox. How long will you?
Dimox,
Yeah.
it's not hard and fast. You have to keep the patient on Dimox and keep getting fundus examination intermittently. Depending upon the fundus finding and symptomatology, you can withdraw that. It's not hard and fast. And those patients, if the patient is obese, you have to, convince them for the weight reduction. That is an important factor. Many of the patients, you can withdraw Dimox with time if the things are taken care of properly.
Okay. So,
So 20 minutes. Pardon?
Papilloedema will be present much before the radiological sign. Some doctors ask.
Yes, sometimes.
Okay.
Sometimes. The fundus can pick up even the slightest. The radiology will pick up the optic nerve is distended. Whether it is giving problem or not will be picked up by the symptomatology and fundus.
Okay.
Okay.
So quickly, I'll touch upon few issues. The first is whether the dura or brain is involved, and that is important in decision making whether to be resected or not. Because if any sinonasal tumor invading the dura or the brain is directly stage 4, advanced one, then dural resection is warranted and the reconstruction is warranted, which is a huge procedure, has its own morbidity and mortality. So that assessment is important. So this is to quickly show you the normal skull base and normal skull base on MRI. This is important. See, what is this black line? Black is bone. Bone. On any sequence of MRI, the air is black and bone is black. On any sequence of MRI, the fat is bright. As simple as that. So see the skull base, intact skull base all the way. This is important to understand. Now going to the next. See this patient had adenocarcinoma and see this thickening of the nodular thickening of the dura. This is involved. See this? The linear thickening of the dura, this is because of inflammation, this is not involved. So the bottom line is nodular thickening is involvement and you have to plan resection. As simple as that. When this hypodense black line is lost, see the black line is lost in this?
Yes.
See the black line is lost here?
Yeah.
That is complete involvement and that is through and through, that is involved. So what see this patient is very important. See this patient has a lot of enhancement of the dura. See here in the temporal lobe, this is thickening on histopathology proven to be malignant. This is just inflammatory. So only the nodular thickening is tumor and that has to be resected. That has to be included in the resection. This is pure involvement of the brain. See this brain edema is involvement of the brain. So quickly I'm going. This is to give you a message. See the CT scan of the patient. What do you think? It's going intracranial, this tumor? What do you think?
You have to see the MRI.
Yes. So CT scan, according to the CT scan, there is erosion, looks like going intracranial. Now look at the MRI. See the complete hypotenuse line intact.
Yeah.
Can you see?
Yeah, very clear.
See how MRI is game changing. Now see, what do you say in this?
Same picture.
Bone erosion.
Bone is gone. Bone is erosion is there.
To the MRI. Same, looks like the previous one, but see the brain erosion. So all these patients need to be evaluated with a nodular thickening. If any nodular thickening of the dura, you have to plan resection. That's it. See the classical picture of olfactory neuroblastoma.
Yeah.
Without biopsy, you can plan surgery. Olfactory neuroblastoma is a classical on the brain surface, peripheral, multiple cyst. That is classical of olfactory neuroblastoma. Without histology, I am telling you. Peripheral part of the brain part, extension, peripheral cyst is classical of olfactory neuroblastoma. Similarly, the involvement of the orbit, I am going fast. Why orbital involvement is so important to discuss? Because in the past, periorbital involvement in the malignancy is considered to be the indication for orbital exentration. That is too radical a treatment. In this era of endoscopy, with a close-up view with the endoscope, with the advancement in the technology of adjuvant treatment,
Yeah.
cannot be so radical and save the orbit many. So this is lamina involvement, periorbital involvement, and pure orbital involvement, 3 grading. So this is normal orbit. See on MRI, this bright is the fat, this is the muscle, and this is the lamina which is intact. Can you see this normal? Now this is the same.
Yeah.
You can see the lamina papyracea bone on CT scan. Now orbital invasion, whether to excentrate the orbit or not, MRI is game changing. See this, the periorbita is intact. See this?
Yeah, very clearly.
You can preserve. You cannot see this olfactory neuroblastoma. There is a plane, hypodense plane separating the tumor from the orbit, going intracranial, but both orbits are safe. Here the muscle is involved. Any orbital muscle involved has to be excentrated. If the tumor is going beyond the periorbita, is the indication of orbital excenteration now. See this? Entire orbit is gone. No question of endoscopic surgery. You have to do open resection, excenteration. So, when to do orbital excenteration quickly? When the tumor involves the orbital apex. That's a narrow area. You cannot ensure a oncologically sound clearance. Once the muscles are invaded, you have to excentrate the orbit. No doubt about it. Okay? So let me quickly. Now, coming to the next topic quickly. As I mentioned in the beginning, this is one of the most important investigation for us now. Diffusion weighted.
Yeah.
This is true bioimaging. True bioimaging means it characterizes the tissue, that what kind of the tissue we are dealing with. How does it? Diffusion weighted MRI, it detects, MRI is what? A magnetic field. Okay? Diffusion weighted MRI detects that diffusion of water molecule in the tissue in the magnetic field. Okay? If the tissue has too much of water content, there will be too much of diffusion. If less water content, there will be less diffusion. That's how it is bioimaging. How does it carrying the value? See the cancer. This patient has a squamous cell carcinoma.
Yeah.
On biopsy later on. On MRI, how can you detect whether it is a malignancy? If the tissue is malignant, means more cellular, more nuclear, bigger nucleus, less cytoplasm, less water content, and less diffusion, and you will find dark on diffusion. So, contrast enhancement, dark on diffusion means malignancy. See the same tissue. Contrast enhancement and no restriction on diffusion, bright on diffusion.
Yeah.
That is not malignant. Any tumor you have a doubt whether it is malignant or not, see the diffusion. If it is no restriction, good diffusion means good water content, it cannot be malignant. What's my point? Simplest.
Yeah. Good.
See this tumor is a child. There's a huge contrast enhancement tumor. This was a rhabdomyosarcoma. And see on diffusion restriction. On diffusion, there is restriction means less water content, more nuclear, more cellularity, less diffusion, and it has to be malignant. Amongst the malignancy, you can find out the highest level of diffusion restriction is in lymphomas. Because lymphomas have highest cellularity. On diffusion, absolutely dark are the lymphomas. So carcinoma, lymphomas, you can pick up. See this patient. This is a tumor lymphoma on PET scan, and on diffusion, absolutely dark. The least diffusion is lymphoma.
Okay.
More over carcinoma. You can diagnose, this is one stage up, I told you I'm going up quickly. So diffusion MRI has a role in sinonasal parotid. This is the study we are doing, this one. Prediction of chemotherapy or post-treatment nodal disease. I give you an example what we are doing. For malignancy of the larynx and hypopharynx, the present treatment organ sparing is chemoradiation therapy. If that works, nothing is required to be done. You can save a laryngectomy. But if it doesn't work, you have to go with a salvage treatment. With a full dose of chemo and radiation given, full dose. After that, the salvage therapy is very difficult. Salvage laryngectomy, complications are more. Tissue healing, infection rate are high, every problem. So what you can do? what we are doing, prediction of chemo and radiation therapy response. All those patients who are on CT-RT, after 3 weeks of CT and RT, we get the diffusion weighted MRI done. If the diffusion restriction is improving, the malignancy is restriction. If it is improving, means there is treatment response. Continue with that. If there is no response, no point in giving a full radical dose of chemo and radiation, take up the patient for laryngopharyngectomy. What's my point? Rather than unnecessarily subjecting the patient for laryngopharyngectomy. Diffusion has a huge value, huge subject to consider.
Is it very expensive, this diffusion weighted MRI?
No. You ask your MRI guy, he will do the diffusion at the same time without any added cost.
Okay.
But you have to ask for it.
Okay.
See, this was the example of the perineural spread I was telling you. From here, the alveolar branches, the tumor was going to the cavernous sinus. See that? A lot of perineural spread, I am skipping it. This patient presented with a facial palsy, had a operated infratemporal fossa tumor 1 year back. From here, infratemporal fossa, along the auriculotemporal, it reached to the facial nerve, and see the facial nerve at the CP angle was involved in the perineural spread. With this much of the perineural spread, there was no fun in operating had this been known earlier. So all such tumors should be assessed with a contrast MRI to see perineural spread. If already there is distant perineural spread, there is no fun in operating the primary lesion. That doesn't get there. All are perineural spread. I am skipping. Okay, just to give you a concept.
Yes.
So finally, before I stop, the future is 3D scanning, intraoperative guidance, intraoperative CTMR, dynamic imaging. They are coming up in a big way to improvise the information they are giving us, the radiologists, and hope in the future that these information are going to be more and more valuable to us in our treatment planning and outcomes. So this is all about. I will skip all this and we can take questions.
If any we can take questions. Questions?
Yes, sir. Dr. Prashant Kevale from Mumbai is asking, in skull-base osteomyelitis, which MRI sequence will you...
T2 weighted and diffusion. See, that's a very important question from Prashant Kevale. We had a patient, it was 4-5 months back, who was being treated or diagnosed as a nasopharyngeal malignancy and was sent for biopsy to us. There was an old male, diabetic, who had a parapharyngeal lesion in the nasopharyngeal aspect, paranasopharyngeal lesion. We got the MRI done. It was amazing to see. It was a malignant otitis externa spreading to the parapharyngeal space, paranasopharyngeal space, which was diagnosed clinically as a nasopharyngeal carcinoma. The reason is how to discriminate without MRI. The MRI, in a minute you can discriminate. The reason is diffusion weighted. In malignancy, the diffusion will show diffusion restriction. Malignant otitis externa is an inflammatory condition, infective with lot of water content, and will not show any diffusion restriction. What's my point? If you suspect a malignancy and there is no diffusion restriction, you have to think twice to prove it. So diffusion is a bioimaging which characterizes tissue's water content. If water content is high, there will be no diffusion restriction and it cannot be malignant. Diffusion restriction will happen when there is high cellularity, less water content, that is in malignancy, and that will show a lot of diffusion restriction.
That is the basic principle, I think.
Yeah, and these are carrying immense value in day-to-day practice, because a single mistake takes you on the other line of treatment. If the lesion is not malignant, you start thinking on the line of malignancy and do something.
One basic question, when we, like for any CA, PNS, squamous cell carcinoma, I don't know, may I ask, after how much time after giving chemotherapy, radiotherapy, you recommend radiological investigation like CT or MRI?
See, after all these head and neck cancers, after completion of the treatment,
Yeah.
The investigation should be done at least 10 to 12 weeks after.
Minimum. Yeah.
Whether you are getting a PET scan done, whether you're getting a contrast MRI done, until the inflammation is subsided. Otherwise, you'll get a false impression of a recurrence in the post-operative inflammation. So one should wait for at least 10 to 12 weeks.
That is
Okay, sir.
and
for that, identifying the recurrence, whether it is in the neck or infratemporal fossa, medulla, anywhere, CT scan will never be able to identify truly between the post-op fibrosis and recurrence. It is the diffusion-weighted MRI which can easily pick up. Fibrosis, post-op inflammation will have no diffusion restriction, good water content, and recurrence will show diffusion restriction. As simple as that. So diffusion MRI is game-changing.
Moni, is how you manage your cases in medical college where they cannot afford the regular radiological investigation like CT, MRI, like that. How you manage those cases?
Luckily, at our place in SMS, the rates are very subsidized. You know, a CT scan would be done at 700 rupees. So that's how economic it is. And in fact, many a times they are also not charged, right? So it's even made totally free for poor patients and all those categories which you have. So yeah, we do end up, getting investigations for majority of them. So not something which is an issue.
Okay. Any more questions, Paramita?
No, there are many more questions regarding the surgical aspect. So I think these questions I'll again sort them out and I'll ask them in the next session.
I think during surgery, we can discuss all these questions.
I have many surgical aspect questions, so maybe
yes, anytime.
Satish boss,
yes.
I want to know. मैं जो आपसे पहले भी discuss कर रहा था कि when would you advise, let's assume, a flare sequence in MRI PNS or a stir sequence in MRI PNS. The T1 T2 चलो समझ आ गया. When would you advise flare or stir, for example?
See, flare sequence is basically advocated to identify the biochemical change in the fluid. Like for example, PNS, it has hardly any value. I give you where we get done most frequently. Two regions in the autology and lateral skull base, I get flare sequence always. Like for example, first let me tell you about the skull base, lateral skull base. Whenever I am doing acoustic neuroma, patient having a good hearing, flare is what? It will pick up the slightest biochemical change in the fluid. On flare inner ear MRI, even a slightest involvement of the inner ear, which may not be translated into audiogram to give us hearing loss. The flare MRI will show the change in the composition of the inner ear fluid, and that dictates that you are not able to preserve the hearing, whatsoever the hearing preservation approach you use. Number one. Number two, in sudden sensing during hearing loss cases, to prognosticate, we tell our patient, every time patient asks, coming to you in a day or 2 or 3 days, you start with a steroid, intratympanic, whatever. Patient asks, will I improve, doctor? And you have no answer. You may or may not. For that prognostication, you can get a flare sequence. On flare, if you find any slightest change in the cochlear signals, fluid signals, that is a negative projective sign that he is not going to improve.
One very basic. Sorry.
So flare is a different sequence to be used differently for different indications. That's why I told you, being surgeons, we need to know which MRI sequence to be ordered at which place. Because radiologist is blind. You write, then only he will do. That is why the onus on us to know about this radiology, that what investigation will give the best information.
Acha, now, एक चीज और पूछ रहा था मैं. Now, when you talked about hypoplastic maxillary sinus, right? Initially, slides में.
Yeah.
If you were to talk about, at the same time at silent sinus syndrome.
Yeah. Yes. Almost same thing.
Yeah. So radiologically, जो मेरे को पता है वो मैं बता रहा हूँ, आप उसमें ऐड करो. What I know about silent sinus syndrome is you would have enophthalmos along with it.
Yeah, it can. Yes, the orbit tends to fall down.
Yeah.
Because of that. Yes.
Any other radiological difference, or they are absolutely similar otherwise?
The same, almost same.
Almost same. Okay.
Yeah.
Hey, how much is
But
how much is beta to transferrin cost for the test cost? Or someone is asking very practical question.
different labs, different prices, but about 10,000.
Because there's a very practical question. If you subject a case to CT MRI, CT sonography, CSF not found, we are not able to find this CSF, then gadolinium enhanced MRI, again we are not getting it. So it is more expensive than sending patient for the beta to transferrin.
See, see, beta to transferrin has a different value. CT MRI has a different value. Beta to transferrin is to prove whether there is a leak or not.
Yeah.
By subjecting the material for the biochemical examination. But for that, you need to have enough CSF to be subjected.
Yeah.
Now, CT MRI has a value in localization.
Yeah.
You have to club together. You cannot replace each other.
We find the site also, we find the whether leak is there or not. Both the things we can find out whether.
Yes, both are complementing each other.
Yeah, we both are complementing.
Satish, beta to transferrin is rather important nowadays, or beta trace proteins are important?
Beta trace protein are also done, but not very specific, because in a lot of hepatic renal diseases, and others, the beta trace protein is raised. It's not very specific. Beta 2 transferrin is very specific, except some issues in the aqueous humor if you have, that can react. Otherwise, the beta 2 transferrin is very, very specific for the CSF.
Yeah, because I was somewhere.
A lot of people get beta trace protein done, but it's not very specific like beta 2 transferrin.
I was just confused which one is better.
No, beta 2 transferrin is always better.
Beta 2 transferrin is more specific.
But beta trace protein investigation is simpler. You can get anywhere done, faster and less expensive, but not very specific.
Okay.
Maybe just to end, a very basic question. Actually, many are asking the similar kind of question, that what is the landmark you would look in a revision kind of revision cases in CT scans? Which is
CT scan, yes. In revision cases, revision are always challenging anywhere. And revision, CT scan is immense value. Sometimes you need image guidance also, because in that situation, if your confines of the paranasal sinuses are broken by the previous surgery, like the lamina is gone, the skull base is descended at some places, you have to be more careful because of the previous scarring or something. It can lead to problem. And that's why you need some time the image guidance help. Secondly, intraoperatively also, you have to go by the landmarks. I will show you intraoperatively. There are certain landmarks which are never lost. How many times the revision surgery is being done, the sinus surgery, particularly sinus surgery. And even if you find a single landmark, you can do the entire surgery. So that I will discuss. Like, for example, the frontonasal process. If the patient has undergone 10 times sinus surgery, frontonasal process is almost always intact. If you find that, you can go to the beak, frontal sinus and carry out the entire surgery. So landmarks depend. There are certain landmarks which are never lost, and take the help of them, which are more reliable. CT scan will prime you with how difficult the situation is going to be, how the previous surgeon has destroyed the anatomy, which can make your life difficult. It can prime you. Okay. You have to stay careful in any situation in revision.
Yeah. Still more than 5,300 people are on but I think that we have to keep the time limit. Almost 4.5 hours are over. So, but I think we have to wait for next 3-4 days. And we are meeting again on Thursday, 5:30 for the live surgical demonstration, followed by talk on complications. In the meantime, the remaining questions we can take at that time during surgery or in between the time. I think it is for that. I think we can call up the whole day.
Yes, sir. Sir, Mahendra Varman here, 4 hours non-stop marathon. And I think so much of energy. Doctor, you have so much of energy. No words to express my thanks to you. And I'm really wondering, our entire team actually wondering, how come you are speaking for 4 hours? So non-stop. You are great.
I will again convey my thanks to Sun Pharma, Pachori boss, Paramita, and my dear brother Monish, and everyone who spared their valuable time. to bear with me for such a long period.
Thank you, sir.
So,
Thank you.
Thank you.
Sir,
Thank you so much.
Thank you, sir.
Pakistan,
Raju sir, Raju sir, next meeting Thursday, 5:30 IST.
IST, I will just try. Until it finishes. You want to say something, Paramita?
I'm saying from Pakistan, Afghanistan, they are all messaging that Dr. Satish Jain sir is in university. It's in university.
My friend from Australia is saying right now it is 3:40 in Australia. Still he is. There's so many friends from Australia there. They're still seeing it. It's almost 3:40 over there.
Yes, sir.
I think we should call for the day. And Moniz, anything?
Wonderful. I mean, I think Paramita's words were something which was the last word is he is a university in himself, right? We people are privileged to work with such people with such great knowledge. It's
but an honor actually working with you and moderating you and discussing with you.
You are champion, Monish.
So people in Jaipur are lucky, and I'm especially lucky because of the relation which I have. I'm luckier than majority of people in the world, actually.
Yeah.
Thank you very much, all my friends.
Thank you, sir. Thank you.
Satish, Moniz, Paramita, Salmanji.